So, good afternoon. My name is Grant Isdale. I'm the General Manager of Campbelltown and Camden Hospitals, for those that I have not met from around the traps yet. The lighting's a bit bad there. And I'd like to extend a warm welcome to the 2022 Macarthur Health and Medical Research Symposium. So today provides an opportunity to showcase the research by clinicians from Campbelltown and Camden Hospitals and our affiliated education facilities. So usually at this point, I would like to provide advice regarding fire escape routes, toilet facilities, breakout rooms, etc. But instead, being in the virtual domain, can I please ask you to keep your computers on mute and place any questions in the comments section while the presenters are presenting, and they'll address them later in the session. So presentations you'll hear today come from clinicians with a diversity of experience. Some are starting out conducting research on everyday clinical practice, others are completing high degree research, and others are world leading researchers and professors. So session one will provide an overview of the 4 of the 5 pillars of the Macarthur Medical Research Centre, being Indigenous Health, Diabetes, Addiction Medicine, and Paediatrics. Unfortunately, mental health are unable to participate today due to some unforeseen circumstances. Session 2 will include oral presentations and poster displays. And session 3 provides information and helpful tips to assist researchers to navigate ethics, literature reviews, and research design. It's an exciting time for health and research across Campbelltown and Camden Hospitals, with the commissioning of our new clinical services building only weeks away, and the planning for the Macarthur Medical Research Centre well advanced. And I believe Professor Hennessy is giving us an update on the MMRC during the course of the presentations. As we know, research is an integral element for our hospital's future, and being a modern health provider, evidence-based research is critical to ensure we're providing appropriate, effective, and accessible care to our patients and our community. I look forward as we move into the future to expand the collaboration with our clinical, academic, and industrial partners, including Western Sydney University, the University of New South Wales, and the Ingham Institute of Medical Research, who will all be partners in the new to-be-built Medical Research Centre. So I'd now like to invite Professor Auntie Kerry Doyle, Associate Dean from Indigenous Health and Western Sydney Uni, for the acknowledgement of country.
Thanks, Grant. Thanks, Grant. As part of our commitment to our reconciliation and the Uluru Statement from the Heart and to closing the gap, we always have an acknowledgement of country. So we know that this country has people who call it home all across the land, and the earth is our mother and she knows all our footprints. So let us together acknowledge country, acknowledge people, acknowledge the elders past and present, and acknowledge each other as we go forward in friendship and continuity. Thank you.
Thank you, Auntie Kerry. So I'd now like to invite Professor Anne-Marie Hennessy, Dean of the WSU Medical School, who will be our chair for the first session.
Thanks so much, Grant, and welcome everybody. Very exciting opportunity for us to showcase the research. So you'll see in front of you the slide at the moment, and just to continue on Grant's introduction, we're going to just in this session do a little bit of scene setting about the themes and the approach that we've arrived to through really extensive consultation from all of our colleagues about what are going to be the characteristics of the Macarthur Medical Research Centre going forward. I'd like to thank Auntie Kerry for her wonderful welcome, and welcome Nathan and other Aboriginal colleagues who are on our seminar today, and just to say that it's an important part of our plans together in the Research Institute that we're centred around the needs of the broader community, but with a particular focus. So we'll just move to the next slide. I just wanted to do an overview of what the area Southwestern Sydney Local Health District approach to research has been. And in our consultation processes, if we look at the wheels in the back of this diagram, we're really wanting to create a network that's centred around the wonderful work that Ingham and Liverpool and the area have done in establishing the research themes that are coming out of the Liverpool and Ingham axis, recognising that as the area health service goes forward, or the local health districts go forward, we'll be planning options for research that we'll be undertaking at Bankstown over the next decade. But today is about what's going on at Macarthur and the themes that have come forward through our consultation process. So if we move to the next slide, I can just demonstrate to you that we worked very hard on coming up with some of the principles of how we looked at research that was themed within our plans. We looked at core themes and supportive themes. I'll come back to those in a moment. What might be emerging themes, because look behind Grant there, that marvellous new building that's going to take our community health forward as we open that up in the next couple of months. You can see behind Grant there's a medical school, the clinical school beside that picture, and the third part of that precinct locally is going to be the MMRC, or the Macarthur Medical Research Centre, and what happens there. So through the consultation, as Grant has indicated, and as you've seen in the themes opening today, we're going to have diabetes, mental health, paediatrics, Indigenous health, and addiction medicine as being really some of those core themes. Next slide, and you can see that that intersects with these other concepts of supportive themes, emerging themes, and what might be shared platforms. And I think as we go forward and create the best environment for all of you undertaking research locally, we're going to want to share around the expensive parts of what we do in terms of laboratory access and tissue banks and facilities like the radiation or radiology facilities that are very expensive and can't be replicated, but at the same time see those core recognised and reputation building themes that meet the needs of our community. The next slide demonstrates to you, we'll be able to share these for you and they'll be on the recording, but if we move to the next slide, you can see that we've got supporting strategies around other themes that are that exist in the Macarthur research ecosystem, particularly cancer that's undertaking local clinical trials and local radiation oncology trials, the stroke and ageing work that we do, the women's health work, and how that intersects with both renal medicine, with psychiatry or mental health, and of course with paediatrics, work on cardiovascular diseases and disability, and critical care, for want of a better term, that encompasses anaesthetics and emergency care that will be expanded as we go forward, and how much of this work is contributed to by the wonderful multidisciplinary teams that undertake translational research locally. Now the big reveal, Grant, the next slide, is what the building is going to look like, and the architects are being tendered shortly. You can see there on your far right-hand side, the side of the medical school. This building will be on the current helicopter pad, but a gorgeous toned building that fits in with the park and the environment. And in the centre there, you see a grass-covered walkway that will walk you through an open precinct to encourage the idea of a learning and research precinct that sits adjacent to that building. On your far left-hand side is the helicopter side of Building D, and there'll be connectors and walkways between those buildings with a lovely 3-storey, 4-storey clinical research building and facility that's going to connect with the conference facilities and really take us into the next generation of researchers. The next slide just demonstrates where you'll arrive as you come through that gorgeous link into a learning precinct with yarning circles, areas for children's, given our children to be with their families, given our focus on adolescent and paediatric research, and I hope a very friendly and encouraging environment for the kind of work that we want to undertake. The last slide there just comes back to this notion of shared platforms, and I bring that to your attention because what we want you to do as you think through the presentations today are not just the wonderful work encapsulated in each of the presentations, but how that speaks to a shared journey and what are the common spirit of cross-cutting themes that we're going to see in that research that will encourage you to think about better ways of working together so that we get the best possible outcomes. So thank you. We can finish with those slides there. To take us back to the program, I'll be chairing this first session. And as we go through those 4 main core themes, I'll invite our wonderful colleague, Nathan Jones, from the area office in Indigenous Health to take us on the next part of our journey. Thanks so much, Nathan.
Thanks, Anne-Marie. Appreciate the opportunity, everybody, to present. Next slide, please. Yeah, so just want to thank Annie Carey for her wonderful acknowledgement. I'd also just want to acknowledge the traditional owners of the land where we're meeting. For us in Aboriginal health, it's always important for us to think about our cultural context and be cognizant of the land that we're meeting and working on. And for us here in Southwest Sydney, we cover the lands of 3 traditional Aboriginal nations. So in the Wingecarribi, it's the Gundungara. For us up here in Liverpool in the northern part of the district, it's the Darug and the Cabral people. And for you guys down there in the Macarthur, it's the Dharawal. I'm the Director of Aboriginal Health. I've been here for the last 10 years. So Nate, grown up in Southwest Sydney, so born and bred, but my traditional connections are back up the north coast along Bundjalung country around Grafton and a little bit further down around Tari and Foster, which is Biripi and Warramai country. But Southwest Sydney is absolutely home for me. So I feel very privileged to work in this position, supporting the provision of health services to our Aboriginal communities here in Southwest. What I wanted to do with my presentation today was talk a little bit about some of the principles that underpin the way that we do research in Aboriginal health, and that are going to be fundamental. Sorry, just back to that previous slide. That are going to be fundamental to the way that we work through this new sort of collaborative. And we're very pleased. It's fantastic that Indigenous health is one of those sort of foundational programs, one of the 4 priorities. So we're really pleased about that. I wanted to give you guys a bit of context about Aboriginal health in terms of some of the key health indicators here in Southwest Sydney at the present. Talk a bit about our current research initiatives and the things that are on the boil. I really wanted to highlight and focus a bit on our academic partnership with Western Sydney University and Dharawal. That will drive a lot of the work through the collaborative, and then probably finish up with a bit of a yarn about some of our future research priorities. Next slide, please. So just, I guess, for us, principles that underpin our approach. I think it's important to acknowledge from the outset that there's probably been, it's been a challenging sort of history, I guess, between Aboriginal communities and researchers in the past. There have been lots of examples of where research hasn't been done well in terms of the way that communities been engaged or empowered, the type of research that's been conducted, and most importantly, in terms of making sure that the research is translational and that we're supported around progressing outcomes out of that work. So I think that challenging sort of context we're coming from is really, really important to always have in the back of our minds, and to really shape the way that we engage with Aboriginal communities about research and think about our research agendas here in Southwest Sydney. So one of the critical things for us is making sure that our priorities are locally driven and are things that are particularly relevant to our communities. I think one of the challenges for us in the Aboriginal Health Service is that we're often approached about all sorts of research initiatives that are often on the periphery in terms of priorities for our community, or are more about furthering specific research agendas that are particular to people. What we want to get away from, we absolutely want to get away from that and have much more of a focus on engaging our communities around the research that's important to us, that's focused on improving the outcomes in the key priority areas for our communities. We're hopeful that over time we're going to build the capacity of Aboriginal researchers, and we'd love to have a network of Aboriginal researchers out here in Southwestern Sydney. And look, that's a lot of the work that's already happening through Arnie Carey and her team over at Western Sydney Uni. For us, the research that we want to participate in is translational and supports practical change to the way that we deliver care and services to our community in Southwest. And you'll see when I talk about some of the examples, you'll get a sense for how we're doing that. A big thing for us too is making sure that when we do our research, that we've absolutely got Aboriginal people engaged in the process around data analysis and interpretation, to make sure that the results that we're seeing are meaningfully interpreted and that we don't have any miscommunications or calculations. That's one of the things that I've seen over my 20 odd years in Aboriginal health, is that often we do extensive consultation with our communities that can come back. It's unpacked in a particular way. And if you haven't got good input from Aboriginal people that understand the context, some of that data can be misinterpreted. So we're very focused on making sure that we've got good Aboriginal engagement at all levels of our research. And that feeds into that last stop point there around the Aboriginal Medical Health and Research Council sort of ethics requirements that are very robust and we all need to contend with. Next slide, please. So just a bit of context for Southwest. We've got the largest Aboriginal metropolitan population for a local health district. So we've got over 20,000 Aboriginal people in our boundaries, and we're the third largest in the state, only behind Hunter, New England and Western New South Wales LHCs. So we've got a large population. It's an urban population, and it's a population with a range of complex health needs. Just in terms of some of our hospital data, and I guess this kind of drives the areas that we want to focus on moving forward, is that unfortunately dialysis remains the primary reason for hospitalisation for Aboriginal people in Southwest Sydney. We have 3 times the hospitalisation rate associated with dialysis. Mental health remains a challenge, and we have twice the rate of the general community around mental health. These next few indicators, I guess, start to talk a little bit about how safe and how responsive our services are in Southwest Sydney, particularly from a health perspective, and highlight where we need to do some work moving forward. One of the big ones and one of probably our most significant challenges is the fact that we still have a very large proportion of our community who, when presenting to our emergency departments, don't complete treatment. So we're sitting at about 11%. Last look, that's not quite, but it's almost double the rate of the non-Aboriginal community. Similarly, the proportion of Aboriginal patients that discharge against medical advice from our inpatient areas is an issue. It's not quite as significant in terms of the percentage number, but it's higher than the non-Aboriginal community. So we sit at about 3.5% of our inpatients still discharging against medical advice. Next slide, please. An area where we've seen some positive movement and where we've invested a significant amount of time and effort in terms of kind of redesigning the way that we provide care and services is around unplanned readmissions. And what we've been able to see over a number of years is a steady sort of decline in the unplanned readmission rate for Aboriginal patients. So at present, we sit at 7.1%. Still a couple of percentage point gap to the non-Aboriginal community, but it's trending in the right direction. And one of the research projects I'll touch on a little later, we'll talk a bit about some of the work we've done in that space. An area where we are starting to see some meaningful movement and some positive sort of transition in terms of data is in the antenate and maternity space. So over the last few years, we've got much better at engaging our mothers and families to make sure that they're presenting at that key 14-week benchmark for their antenate presentations. So we're up to 75%, and that will be one of the better rates in New South Wales. Similarly, we're starting to see a reduction in the proportion of low birth weight babies. For us as well, we're down to 9% when that's been as high as 16 and 7%. Smoking cessation remains a challenge, but our rates of mothers quitting in the second stage of pregnancy are the best in New South Wales. So we have approximately 40% of our mothers in that second stage ceasing smoking, it's great that we're the best in the state, but we'd love that number to be much higher. And the area that we really shine is around our immunisation rates, where we've got better immunisation coverage at 1 year, at 12 months of age and 5 years of age than the non-Aboriginal community. Those maternity and antenate indicators kind of reflect the significant investment we've had over the last few years in improving service responsiveness and growing our Aboriginal child and family programs in the community. Next slide, please. Next slide, sorry. Not going. Oh, yeah, here we go. So look, just in terms of some of the research projects that we've recently completed, we were very fortunate a couple of years ago to get a translational research grant where we very much focused on improving our transfer of care for Aboriginal patients. And I feel like this program and the work that we've invested in our big hospitals at Liverpool and Campbelltown, setting up Aboriginal transfer of care teams that focus specifically on supporting discharge for Aboriginal patients, is part of the reason that you're seeing that improvement in unplanned readmissions. It was our first endeavour at one of these translational research grants, and we saw some really positive changes Unfortunately, the quantitative data wasn't where we would have liked. We were a little bit ambitious in that, but our qualitative data was fantastic. We've recently completed an evaluation of our Aboriginal Got It program, which is a mental health early intervention program, looking at conduct disorders that we piloted on behalf of the state. And we've had some phenomenal outcomes. We did that in collaboration with the Sachs Institute, and it's really highlighted the benefit of culturally adapted programs and the importance of looking at your therapeutic interventions and how you incorporate culture. There are a few other of our research initiatives there covering things like antenatal oral health, sexually transmitted infections, and also a little bit around COVID. Next slide, please. Next slide. Sorry, having a bit of trouble with the slide. So look, just a couple of our research posters, and you'll notice that the couple of graphics are embedded in my presentation. These were significant. This is from our translational research grant, and what they really highlight is, again, the way that we've kind of depicted the research from an Aboriginal perspective. Those couple of graphics with the animals there are significant because they represent totems for Southwest Sydney. The goanna is the totem used by Gattingara Local Aboriginal Lands Council, and the lyrebird is the totem there for Darrell Aboriginal Medical Service, but also for the Darrell people in that Campbelltown area. And it's also reflected on the front of the hospital, you'd see in that little background with Grant. Next slide, please. This poster as well was just an example of how we used, I guess, kind of the Dreamtime story concept to communicate some of the research outcomes. And again, it really highlights the importance of embedding culture in the way that we do research and thinking about the way that we communicate it to our Aboriginal stakeholders and communities in a way that's meaningful and speaks to them. Next slide. All right, so the current projects that we've got in progress at the moment are around breastfeeding. That's an area where we need to do some more work, and we're looking at some specific work around developing particular resources that are for our community around encouraging breastfeeding. We've also got a major evaluation of one of our Aboriginal Child and Family Services, the Tutor School programs, and we're about to engage in a new research program looking at cancer services and patient experiences for Aboriginal people engaging with cancer services in Southwest Sydney. Next slide. I guess this is where I really want to focus because this is the future for us in terms of our research agenda. We've got an amazing academic health partnership that I don't think would probably exist in any other LHD, where we've got a formal collaboration with Western Sydney Uni, Darrell Aboriginal Medical Service and the local health district that will drive our research into the future. Very fortunate that Annie Carey is heading up that unit for us and will lead that work. And those principles that I discussed earlier are all the things that are going to drive that agenda that is coming out of that unit, ensuring that our research is locally driven and translational, that we're building research capacity, and that we're building the cultural competence of our clinical workforce here in Southwest Sydney. Next slide. I'll just quickly mention a couple of these, but in terms of the big research priorities coming up for us, we've got a translational research grant at the moment for the metabolic clinic model that we've developed out at Darrell Aboriginal Medical Service, which is significant. And we do a lot of this, guys, is where we translate specialist models that operate from hospitals and put them in community controlled settings. It's a much different undertaking because of the size of the metabolic clinic and its multi-disc nature. So we're really excited to evaluate that model and look at its impact. We've also got a large evaluation that we're planning around our Aboriginal Child and Family Services because we've got a significant investment in sustained home visiting, looking at early childhood development for children aged 0 to 5. Last slide, please. So I guess where we want to be moving forward is we want our academic health unit fully operational. There's still a few positions that we're recruiting to. We want to have a consistent Aboriginal health research agenda that's local and developed with our partner organisations like Darrell and Gattingara Land Council. And we want to make sure that we've got a network of Aboriginal health researchers here in Southwest Sydney that are well supported, that are local and are driving our research initiatives into the future. Thank you.
Thanks so much, Nathan. That's just fabulous. And beautifully presented. I mean, the lovely touch points with the program around paediatrics and mental health that's articulated in your figures, confronting as they might be. So if it's okay with you, we might set you the other core theme presentations, then come back to questions collectively at the end of this session, if that's okay. So keep your questions going. We'll keep an eye out for them, and we'll move on to David Simmons, Distinguished Professor David Simmons, who's going to present on diabetes for us. Welcome, David.
Hello, everyone. David Simmons. I'm pleased to be able to present on some of our research activities and plans for the MMRC. I'm sorry I can't be there with you today. I'm the director of the Macarthur Diabetes Endocrinology and Metabolism Services, or MDEMS, but also the director of DOMTRU, the Diabetes Obesity Metabolism Translational Research Unit. As many of you will know, there's an epidemic of diabetes and obesity. So there are over 64,000 people with diabetes in southwestern Sydney. That's about a sixth of the New South Wales diabetes population. And about a quarter of hospital inpatients have diabetes. They may not have come in with it, but they have it, and it's impacting on their length of stay and their survival. And we really are in the middle of this epidemic. We've been undertaking a range of research programs to mitigate the impact of diabetes and potentially to prevent it, including a program in diabetes and pregnancy, integrated diabetes care, preventing complications, prevention and screening, education for healthcare professionals and people with diabetes, and trials. And we've been remarkably successful. We've just completed recruitment into Toboggan, a randomized trial of treating early gestational diabetes. And the International Association of Diabetes and Pregnancy Study Groups will now have a summit to discuss the findings of this with an international panel to see how we can use these data to define early gestational diabetes and how better to manage gestational diabetes. But we've also been leading a national diabetes and pregnancy benchmarking program across Australia and New Zealand. We've been involved in the Canada-funded the Mighty project of using metformin in type 2 diabetes and pregnancy, and also the Danish-funded randomized trial of a new insulin called Degludec in pregnancy, and a range of other diabetes and pregnancy studies. And more locally, we've been looking at how better to improve the working together of those in the community and hospital teams, for example, with diabetes, but it can also be obesity. This is the Wollondilly Diabetes Programme, working closely together, and we've improved the glucose management, and this has lasted for over 3 years, and has a range of other components as well. From there, we learned more about how to do what's called case conferencing, where an endocrinologist works with general practice within the practice, advises them on management, lasts about 15 minutes, and through that advice, through perhaps a single visit of 15 minutes, the HbA1c has dropped by 1%, which is the equivalent of about 20–25% reduction in diabetes complications, trying to turn around this whole epidemic. And the success of this is shown by the inclusion of our work within not only the Southwestern Sydney Diabetes Framework, but also state policy, which is about to be introduced as an initiative for diabetes management across the state. We've also been looking at prevention with a pilot, Latawa Afua, with Pacific people in churches, and that was successful in reducing glucose in the community and also blood pressure. And we were fortunate to win an NHMRC-funded program for prevention among the Pacific community across of diabetes and improving obesity across 4 districts in New South Wales. And of course, we're always looking at ways to improve the care of those who are within our hospital services, whether that be young adults with type 1 diabetes and young adults with type 2 diabetes as well, trying to increase, for example, contraception use to try to reduce the chance of malformations in babies born from women with a high glucose at conception. And we've also run a program for diabetes remission in type 2 diabetes, where 88% had gone into remission by 3 months. And we have a whole range of other audits and studies of diabetes with our hospital population. But these have been very hard. Collecting the data has been very laborious, and recruitment has also been very laborious. So along comes the MMRC, and we have this clinical cluster 1, where we have a research clinic, research assessment zone, and a workspace for our team to be. And our vision is really a radical shift from where we were. We want to move all of our major clinical activity into the MMRC to systematise data collection on all of those people coming in. It's not our metabolic rehab clinics, they're in Camden. Our diabetes and endocrinology and pregnancy clinics works closely with the maternity team, the women's health team, and the inpatient emergency are obviously in situ. But we're looking at clinical and primary research data collection to be collected systematically and prospectively with high ascertainment and accuracy instead of the current laborious, incomplete retrospective audits, which are very difficult sometimes. And with the appropriate level of administrative, research nurse and research assistant support, we'll be undertaking data collection on, for example, clinical status, mental health, patient perspectives, quality of life, all of these kinds of PROMs and other measures, and also complications, physical manifestations, the eye, the feet, natural history of different complications and a metabolic state. We'll be looking at new biomarkers and new technology. And our vision is that every single patient that comes into the cluster will be invited into research, and it may be through the use of their clinical data during routine care. But it also may be into surveys, qualitative research, pathophysiological studies. We'll ask them to provide additional research samples, not just blood, but urine, even tears, for example, DNA or microRNA. We'll ask them to come into research in the research assessment zone, and obviously have others that we invite in as well through our network in for example, primary care in the community, technology research, and into trials of insulins and other injectables that are here and coming, medications, devices, service changes, behavioural interventions. But in parallel, and I think this is really important, we're looking for a cultural shift from us doing our work in a clinical space to somewhere where knowledge is also at the forefront, not just caring for those people with diabetes, obesity, and so forth, endocrinological issues. So every member of MDEMS, every staff member, would have an educational role and be supporting or undertaking quality improvement and research projects, and perhaps doing further qualifications. And here we have our 4 podiatry rooms in this research clinic, eye screening, different interview rooms, places for questionnaire and measurement collection. And you can see how people would flow, coming to the reception, waiting area to complete their questionnaires, over to some measures, and then going to wherever their appointment is, perhaps going to eye screening first, and then to the others, whatever's needed. And then for those that come to the research assessment zone, we've got group research, including a research kitchen, which we're very excited about, temperature-controlled rooms for what's called insulin glucose clamps, where you can keep the glucose at a particular level and see how much insulin is needed, or vice versa, depending on how you do that. Looking at gait room for those with foot problems or risk of falls, exercise testing. We really want to protect those with diabetes, their feet, because of neuropathy. So we're looking at orthotics, wound materials, and even plaster. Looking at PPOD for looking at young babies, for example, and BODPOD and DEXA for looking at body composition in older people, including up to the elderly, but also children, for example. Then we have an ultrasound room for a whole range of purposes, and an area where we can deal with different samples, including feces, and a freezer bank. And we also have smaller group research, smaller rooms for example, patient education, which again would be part of our research program. Our vision, therefore, is pathophysiological studies, including different blood and samples, but dynamic testing, exercise testing, perhaps we can do muscle biopsies and we can freeze them there to go over elsewhere for more intensive wet lab work. Dynamic foot testing. relationships between complications and metabolism and microbiome, and also relationship with body composition. So this all sits within our DOM-TRU research strategy, looking at partnerships. We're very much a multidisciplinary team with dietitians and educators and many others, as well as medical, looking at our education program through, for example, conferences, trying to influence policy, and looking at trials, working with the community, including health professionals in the community, and trying to work to optimize the use of the available space in southwestern Sydney LHD research infrastructure, including the Western Sydney University MRC. If you want to hear more about our research, please do email us, find us on our website. Thanks to the clinical and research teams, to Southwest, I mean, they really are terrific. Southwestern Sydney LHD for that startup academic unit funding. It was phenomenally useful and successful. NHMRC and other funders, but also the support from Western Sydney University, Ingham and Spear. Many thanks to you all. Thank you.
Thanks, David. So what a wonderful tour de force and a demonstration of what great research leadership looks like. So congratulations on your efforts. But again, I'll just draw everyone's attention to two things, some lovely intersections there between the kinds of things that we want to see themed as core themes in terms of paediatrics and adolescents. I know David and I spoke about tracking that teen diabetics when you first came 7 years ago, David, and there you are publishing those outcomes. So again, a lovely sort of a rounding off of where we hoped we would be at this stage. So we'll again save questions and we'll move immediately on to the next presentation on addiction medicine by Dr. Gilbert Whitte. So welcome, Gilbert.
Thank you, Anne-Marie. It's a great honour to be part of this Macarthur Health and Medical Research Symposium. I first went as a doctor to the Macarthur area to provide services in 1989, and I saw some of the first patients in our new, was then facility called Cooper's Cottage, which was a little cottage on the hill away from what was then the main part of Campbelltown Hospital. But I'm pleased to say that the drug and alcohol services in Macarthur are now very much integrated within the Campbelltown Hospital and also the other health facilities across the Macarthur region. So can people see my slides?
Not yet.
So it's, whilst they're sort of coming up, I want to say that thank you to Auntie Kerry for the acknowledgement, and particularly to Nate Jones. What a fantastic presentation that was about the research that is going on through the Aboriginal community. In the Macarthur area, I've been seeing drug and alcohol Aboriginal patients in the drug and alcohol service since 1990, and we've had an outreach clinic at Thurrawal Aboriginal Medical Services for many years now. So it was really great to hear Nate's vision for research in Aboriginal health in Macarthur. And we have many partners, but there are sort of none more important than our Aboriginal health partners. So thank you. The Drug Health Services current research focuses on understanding whole person determinants of substance use and related problems and developing innovative models of care and treatments. Next slide, please. And our research streams include this acronym that we're very pleased with, the Multi-Disciplinary Addiction Research and Translation stream. And that is really an attempt to try and build up our own infrastructure and to assist our staff to be able to do research, and very much translational research, as everyone else has talked about. But we do have key partners. We're part of the New South Wales Drug and Alcohol Clinical Research and Improvement Network, which puts us as partners with most of the other major local health districts in New South Wales and non-government organisations. And of course, universities such as Western Sydney University and University of New South Wales are also key partners for us. Next slide, please. So we've been trying to develop some governance around our research, and we have a research steering committee in the Drug Health Service and a research action plan, which is developed and aligned with the district's research strategy. Next slide, please. So our research action plan includes 4 major efforts. One is around the research capacity building and support, which I've mentioned, and that is in partnership with Western Sydney University, and goes alongside a lot of what Nate was talking about earlier. Strategic collaborations, again, with a range of partners. Consumer and community partnerships, really important. Involving drug and alcohol consumers in health service development has been a challenge for drug health services, but I think we're getting there. We've got a consumer participation involvement in our research committee and through DACRN. And finally, utilising the research results to inform changes in policy and practice. So along the lines, again, of what Nate and also Professor Simmons was talking about earlier, very much wanting to develop translational research. Thank you. Next slide, please. So some key priority areas for our research. The first is around priority populations. So we've been looking at what happens in the cold community with regard to drug and alcohol problems, women, an important group, and Aboriginal health research, as already been mentioned. Then we're looking at models of care for our patients and their journeys through the health system and the drug health system. We're looking at oral health and the connection between drug and alcohol services and oral health services to better support patients who require both of those services. We've looked at gambling, which is a bit different for drug and alcohol services. But we think it's an important area, and the research is showing that. Consumer experiences, I've said, particularly focusing on hepatitis C, trying to find better ways of innovative ways of getting people tested and treated for hepatitis C. And one of our really great new projects is the Drug and Alcohol Youth Service in the Macarthur area, which is a relatively new service, but really has changed the way drug health thinks about what it does. I think drug health services have traditionally not been good at accessing young people, and particularly young Aboriginal people and young women. But by having a drug and alcohol youth service that includes an Aboriginal worker and other workers who are really good with young people, we really have accessed a whole group of people in need of services that previously couldn't or didn't access our services for a range of reasons. And we want to have a research focus for that. Finally, AOD treatments. We're looking at vaporized nicotine products through a trial at Liverpool Opioid Treatment Program to see whether that is a better way of helping people who are, say, on methadone or buprenorphine who want to stop smoking cigarettes, to see if vaping is a way of helping them do that. And then, as I say, innovative trials looking at hepatitis C testing and treatment to see if we can access patients through the needle and syringe exchange programs through things like dry blood spot and point of care testing. Next slide, please. So what of the future? It is very much about the multidisciplinary addiction research and translation stream, and of course, identifying future research priorities and partners in Southwestern Sydney Local Health District. Thank you very much.
Fantastic, thank you. Some nice data for us to think about and the challenges in there for us. So thank you, Gilbert. That's great work, and what a journey over those years to see the site come to life in ways that are going to be able to support your mission. So thank you. We'll move on to Professor Valsa Apen, who's going to give us the Pediatric Introduction. We're doing okay for time. There might be a few minutes for questions at the end. So thanks, Valsa.
Thank you very much, Anne-Marie. I'm going to go a little bit futuristic here because we do have the best start, which I'll refer to as the kind of current incubator program, but our vision is to establish a Southwest Sydney Institute for Translational Child Health Research switch program in the Macarthur Centre, and with a vision to make Southwest Sydney the best place for children to grow up. The reason being that we all now appreciate non-communicable diseases like obesity, asthma, developmental problems like speech delay, autism, mental health problems. These are the millennial comorbidities, and there is no turning the clock back unless we really, really start early. And they are the biggest health threats. That's the biggest way in which our health services are interacting with the community. And those from the disadvantaged backgrounds are 5 times at higher frequency of occurrence for these new communicable diseases. But if we can start early, childhood represents a golden window of opportunity to change that trajectory and improve things for a lifetime. Next slide, please. So we currently have got a few themes under which we operate. Healthy Beginnings is our first 2,000 days that pregnancy early years. John Whitehall and Lynn Kemp are leading that, but also we have got significant interactions with the Women's Health Group in that first 2,000 days program. Health Systems Research, led by Paul Shea and Cheng Liu, that is where we are interacting with the services to see what model of care might be best applicable for our communities, what tweaking and adaptations do we need to make for whether it is the Khal community, Aboriginal community, etc. The next one is population health. When we are talking about non-communicable diseases, when they come to us in a disease state, it's already too late. So we need to have a significant emphasis of population level interventions, and that's led by Regulingham and Stephen Konati. Across all these programs, there is the data observatory, the BESTA Data Observatory. Again, we interact with the Whitte to get that from the pregnancy onwards, led by Binjan Aldin and Andrew Page. And we've got a vulnerable population and equity group, Sue Wolfenden and Shanti Raman. And this is what we started with. But then we did a lot of consumer and community involvement. We have got a youth advisory council of about 98 young people from the Liverpool Boys and Girls School. And when we asked them for their priorities, the number one priority was mental health. So we added the theme. Of course, I'm from a mental health background, so we've already been doing it, but we brought that mental health theme to intersect really, and it's kind of great to have the theme of pediatrics and also mental health featuring as pillars in the Macarthur Research Center. So it's kind of really good interactions that we hope to have once we have everything ready and going there. Next slide, please. What I will just remind everyone is that in that population from Bankstown to Bordal, which is about a million population, the disadvantage is kind of staggering. 53% are on a weekly income of less than $600. 41% born overseas, almost half not speaking English at home. Next slide, please. Which really has stacked up the odds for somebody. When you are born, you are meant to have a great life, to reach your potential. But if this is the kind of disadvantaged background that you're coming into, then there is a very high chance that you may not reach your full potential. And I'm going to take that story through Ollie's life. Next, you can keep clicking. Mom smoked during pregnancy, so she didn't kind of go for antenatal care. It was great to hear Nate saying that how the antenatal check-in clinic at 14 weeks has gone up to 70%. So it's a very important thing that we need to be paying attention to, that things are identified, looked into, checked up very early in pregnancy, which didn't happen for Ollie's mom. Ollie was born low birth weight. Mom was depressed postnatally and therefore didn't get the nurturing care that Ollie should have gotten. Of course, fussy eater, poor sleeper, which comes as a package in these children and in these disadvantaged families. There was no bonding attachment. So from a mental health, developmental, eating and sleeping, and all of those physical and developmental, psychological, social development were all kind of lagging behind. And by toddlerhood, he was hyperactive. He had a lot of asthma attacks. So they almost went to the ED as a GP service, pretty much. So there was no preventative care, there was no health developmental surveillance or prevention health promotion programs when didn't reach Oli at all. There was no reading or stimulation at home and no preschool because a mom couldn't afford it. And into the primary school, he continued to struggle. Of course, he started school not ready because he had reading problems, he had language delays, he was hyperactive, and he was bullied. And again, he started to become obese. But if you are a little bit hyperactive, if you have got a little bit of learning problem, if you have got a little overweight, there is no service that currently would come and help you out. But that's where we need to be shifting to in order to prevent the next trajectory that you all can guess where he's going now. So by the time he hit the high school, he turned the table. He started to become aggressive. He was with the wrong crowd. Substance abuse followed, obesity followed. He became out of control, started to self-harm. Police was bringing him to the ED. And a lot of that we could have prevented had we provided the right supports much earlier in life, starting from pregnancy. Next slide, please. So this is the stacking stats that we've got to contend with. Obesity rate is 1 in 3. I'm not talking about adolescents or adults. These are 2 to 4-year-old kids in Southwest Sydney, compared to the national state average of 1 in 6. When it comes to developmental delays, nationally, Australian Early Development Census says 1 in 5 children at start of school have got developmental vulnerability. And that is about 1 in 3 or 1 in 4 in different parts of Southwest Sydney. And if you look at that dark shades, it goes with the socioeconomic gradient. The more disadvantaged background or postcode you sit in or you come from, and that's where the highest developmental delays and vulnerabilities are. Next slide, please. So comes the COVID, and children and families have had a very, very, very tough time. And on already existing disadvantage and difficulties, COVID really affected our community significantly. This is a national survey on the left that you are seeing the rates there of the number of school and preschool children experiencing employment stress in the family. And if you look at on the left side, the national 10 suburbs, which came up as most impacted, 3 from Southwest Sydney. Fairfield coming second, then Bankstown and Campbelltown. And it's almost, one have to see that it may be a ceiling effect because Fairfield already was highest in the 2016 stats with more than 10,000 kids who are experiencing employment stress in family. And that 50% increase, making it more than 15,000. But Wyndham in Melbourne went to double the rate. Maybe we couldn't go to double the rate because we are already sitting at the ceiling. And on the right is the Australian Early Development Census developmental vulnerability rates. Again, Fairfield coming up with a 28.2% vulnerability for kids with developmental delays compared to the New South Wales and national average of about 1 in 5 children or 19-20%. Same for Liverpool, Bankstown, Campbelltown, they all follow. So really it tracks the socioeconomic gradient when it comes to children's development and opportunities. Next slide, please. So Southwest Sydney is an area with the highest social disadvantage in all of Sydney, but strikingly, it is also where the highest inequity is happening in access to healthcare. We followed out 2,000 births from Liverpool and Bankstown Hospital, and what we found was that there was an inverse care law. Kids from the most disadvantaged background who had the highest risk for developmental problems, whether it's speech delay or autism or global developmental delay, they were the ones who were least accessing the well baby checks, the Blue Book program, all those prevention, health promotion, child and family health services, etc. So that's where we need to be making the difference. We need to flip that inverse care law into a positive care law. And we have an opportunity to make a difference if you really start early in life, not early in illness. So that's where we can really make the difference in the diabetic trajectory, mental health trajectory, substance use trajectory, and the following complications on liver, cardiovascular system, stroke, etc. Next slide, please. And that's because the neurodevelopment and the development of the brain and the body follows at a very rapid pace in those early years. So you're seeing the synapse connections of the brain forming its own connections. In pregnancy, there's tiny bits of connections. By birth, it's kind of, you can see the shoots coming up. By about 6 months, it's almost like a bush. And by 2 years, it's almost like a forest. And what you do after that, from 3 years onwards, is to prune away things you are not using. But if you're catching a child at 4 or 6 years when they are starting to, oh, this child is not speaking, oh, we should do some intervention. We are already too late from a brain plasticity point of view. And so then we've got a remarkable opportunity in Southwest Sydney to make a difference if we can really, really start our work early in life, and really, really early, starting from pregnancy. Next slide, please.
Just one or more slide, Dulcie, if that's okay.
Yeah, that's the last slide. So this also translates to a economically $13 to $1. So that you can't beat that kind of return on investment. Next slide, please. So no child should be left behind. And if we fail today's children, we are going to fail tomorrow's society. And so this is the time to act, and we have a wonderful opportunity. And we hope the switch will make a difference for the Southwest community. Thank you.
Fantastic, lovely, Val. So again, tour de force in terms of your mission and plan, but a lovely example of intersecting across the themes that are present. Touched on mental health, for example, and I know they weren't able to present today, but that's the other key core theme that we're going to pick up in terms of our plans. Look, we will move to a quick break because we're going to come back at 2:35, so that gives everyone just a couple of minutes to stretch their legs and get a glass of water, and we'll come back for the session 2 being chaired by Professor Baker and Dr. Annette Toniella. And we do welcome questions and comments, so we want you to be thoughtful about the presentations. So pop those into the Q&A and we'll circulate those to the speakers if you get a chance. Thanks, everyone. We'll see you in 3 or 4 minutes.
Apologies, I got feedback from my computer. So I just wanted to welcome everyone to session 2 of this research symposium. I'm Dr. Annette Toniella. I'm the former chair of the Campbelltown and Camden Research Committee. I've handed over to Dr. Milan Pia, who unfortunately isn't with us today, but I'm co-chairing with Associate Professor Elise Baker, who's the past and present co-chair of the committee. So I just wanted to say thank you to everyone who submitted abstracts for this research symposium. I think it's a really commendable effort. The last 2 years has been very challenging. Research, as we know, is often difficult at the best of times, but add COVID to that mix. And I think to have abstracts submitted and you'll now hear them presented, I think is really an achievement, and I congratulate all those who have submitted to today's presentations. So without further ado, we're going to start with the oral presentations. The first one is by Elise Hickey, who's a CNC in the department, Elise Hickey, talking about the prevalence of anxiety, depression and chronic stress in adults with class 3 obesity and the impact on weight loss over 12 months in a multidisciplinary weight management program. And I just encourage you, sorry, Elise, before you start, for those that have questions, if you can please submit them via the chat function.
Lovely, thanks for that. So my name's Elise Hickey. I'm an endocrinology advanced trainee working in the Sydney Southwest Local Health District last year. I'd like to present this study looking at the prevalence of anxiety, depression and stress in adults living with class 3 obesity who have been attending a multidisciplinary weight management program, the Metabolic Rehabilitation and Bariatric Program. This is based at Camden Hospital, and our referral criteria consists of a BMI that's body mass index of greater than 40 kilograms per metre squared, who have at least one obesity-related complication. The team consists of 2 endocrinologists, a gastroenterologist, links to bariatric surgeons at Concord, psychiatrists, a clinical nurse educator in obesity and diabetes, and our allied health consisting of psychologists, dietitians, and a physiotherapist. I think Kathy will speak a bit more about the program in following presentation. Next slide, please. So by way of background, we know that rates of severe obesity are rapidly increasing, both as we've heard in our own district in Australia and worldwide. Health complications from obesity have significant implications for our community's health and vast demand on our health expenditure. In addition to medical complications, severe obesity is often associated with significant psychiatric comorbidity. There appears to be a bidirectional link between obesity and depression, with longitudinal data suggesting adults with obesity have a 55% increased risk of developing depression throughout their lifetime, whilst adults with depression have a 58% increased risk of developing obesity. There also appears to be an association with chronic stress with the development and maintenance of obesity. Next slide, please. So this study aimed to evaluate the presence and severity of these symptoms in this population group, and to explore the relationship between these symptoms and their capacity for weight loss over 12 months within our multidisciplinary weight management program. It's a retrospective cohort study of all adults who enrolled in the program between March 2018 and January 2022. At commencement in the program and at 12-month follow-up, participants were asked to complete the Depression, Anxiety and Stress Score 21, DAS21, with collection of demographic and medical data at these time points. Next slide, please. The DAS21 is a dimensional scale which doesn't allocate patients to a psychiatric diagnosis. However, it provides recommended cutoff scores for different categories. This is divided into subscales of 7 items each, and participants are asked to rate the extent to which they've experienced these core symptoms over the past week on a 4-point severity scale. For depression, this looks at symptoms of dysphoria, hopelessness, devaluation of life, self-deprecation, lack of interest, anhedonia and inertia. For anxiety, this assesses for autonomic arousal, skeletal muscle effects, situational anxiety and subjective experience of anxiety affect. And for stress, it inquires about difficulty relaxing, nervous arousal, increased irritability, agitation and impatience. And this scale has been shown to be able to yield meaningful discriminations between these symptoms across a variety of settings. At baseline for our 178 patients, these are our patient characteristics. The study population had a mean age of 49.6 years, mostly Caucasian ethnicity, and with a female predominance. At baseline, our mean BMI was 51.7 kilograms per metre squared. Common metabolic complications included hypertension in just over 50%, type 2 diabetes in almost 40%, dyslipidemia in 44%, whilst 70% reported joint pain, 46.4% gastroesophageal reflux disease, and about 45% had obstructive sleep apnea. Next slide, please. So this graph demonstrates the percentage of responses in each severity category for depression, anxiety, and stress. For each of these subscales, for depression, 53.9% had moderate to extremely severe symptoms. For stress, 39.3% had moderate to extremely severe symptoms. For anxiety, 51.1% reported moderate to extremely severe symptoms, with 30.3% of participants reporting extremely severe anxiety symptoms at time of joining our program. The DAS21 score was not affected by baseline BMI or presence of type 2 diabetes. Next slide, please. At 12-month follow-up for a subset of 49 patients, they were able to achieve significant weight loss. 57.1% achieved at least 5% weight loss from their starting body weight, while 20.4% achieved 10% weight loss. A negative correlation was found between weight loss and baseline DAS21 stress score and their DAS21 total score. No statistically significant improvement in symptoms of depression, anxiety, or stress was found in this study. Next slide, please. In terms of these findings, we know that in this population of adults living with severe obesity with quite a high mean BMI of 51.7 kilograms per metre squared, we found very high prevalence of symptoms. In fact, more than 1 in 2 participants were experiencing moderate to severe, extremely severe symptoms of depression and anxiety, and almost 1 in 3 reported anxiety symptoms in the extremely severe range. Although high baseline symptoms predicted less weight loss at 12 months, significant weight loss was still achieved by most within the program. As mood disorders and obesity are strongly interlinked, psychological support for this vulnerable population is really critical to improve both mental and physical health outcomes. And of note, COVID-19 did affect our 12-month follow-up data collection, so ongoing future assessment in this population is required. And that concludes my talk. Sorry.
I'll go back. Stop sharing. Okay, I'm hoping that you can hear me now. Sorry, we're having a few issues. Thank you, Elise, for that very elegant presentation. I mean, it really highlights why the MMRC, the focus is on diabetes, obesity, metabolism, mental health. All of those are interlinked and a really important aspect of health for our population out at Macarthur. So thank you. I don't think there's any questions in the chat, but if any occur to anyone, please submit them. If we've got time at the end, I'll bring them up then. So thank you. So we'll move on to our next presentation, which is by Kathy Grudinska, discussing the impact of COVID-19 on a multidisciplinary outpatient weight management program for severe obesity.
Thank you. Am I on? So my name is Kathy Grudzinskis and I'm the clinical nurse consultant of the program. And yes, I'm talking about the impact of COVID-19 on the multidisciplinary outpatient weight management program for severe obesity. Next slide, please. So a bit of background on the program. The metabolic program, metabolic and bariatric program, was initially established at Camden Hospital in 2009. Are we there? Yeah, okay, sorry, is the next slide up? Thank you. Yep, okay. So the program was established in 2009. It's a multidisciplinary team, as Elise just discussed, consisting of specialist medical, nursing, psychology, dietitian and physiotherapy, with clinically supervised exercise classes and some access to bariatric surgery. In March 2018, the program was enhanced by adding 2 extra clinics that had more medical and allied health staff, and it increased access to bariatric surgery, with dedicated clerical staff to assist in reducing the wait list, which had reached 465 by March 218 in that pre-enhancement stage. Next slide, please. So the criteria, as Elise mentioned, for the program is a BMI greater than 40, with at least 1 obesity-related comorbidity, and the ability to attend regular outpatients in an outpatient clinic. Oh, hello. Yep. Okay, go on to the comorbid slide number 17 that you can see. Okay, next slide, please. Next slide, please. Okay. So comorbidities related to obesity are many. Some of you will have greater interest in certain related comorbidities. And for the most, the ideal management of these comorbidities is weight loss, along with a structured medical management plan, of course. Next slide, please. So where are we with obesity in Australia? We have more than 32% of adults in Australia with obesity, and these rates, as previously discussed, are increasing. We know that the prevalence is greater in lower socioeconomic areas, such as southwest Sydney, and we know that the treatment options that are available have minimal public health support or reimbursement, such as the medications available for weight loss have not got PBS reimbursement. We also know that stigma and bias can impede access to services and increase the cost for people with obesity. And there's often little understanding of the complexities of managing people, their physical, social and psychological needs. Next slide, please. So what's changed with the program since the introduction of COVID-19 pandemic? As a hotspot, southwestern Sydney had an increase in the inpatient services needs, which resulted in a corresponding quite dramatic decrease in outpatient services that were available. Face-to-face consultations were no longer provided, and reviews and assessments were conducted by phone. A bit hard to weigh somebody by phone. Clinical staff were redeployed to other assignments to assist in, with their increase in the inpatient hospital needs, and staff were seconded to different COVID-19 clinics and community care functions. And as with all gyms, our patient classes, exercise classes and assessments were ceased. Next slide, please. We became more aware that people who contracted COVID-19 who were with obesity were at a higher risk of mortality, morbidity, and generally hospitalisation. And nursing these people was also more difficult, particularly in the ICU setting. We also realised that the reduction in primary care services was contributing to the worsening of chronic conditions such as obesity. Next slide, please. So we set out to evaluate how these changes due to COVID-19 affected the program. We looked at two-year time periods, looking at the 2 years following the program enhancement that was in March 2018 until February 2020. And then the following 2 years with the onset of the pandemic being from March 2020 to February 2022. And we compared the two time periods with regard to the number of patients on the waiting list, the number of surgeries performed, the number of new enrolments to the program, and the characteristics of these people. Next slide, please. So looking at the waiting list, which had been reduced by the enhancement that had been in place to 197 by the pre-COVID time, but which increased to 430 following the pandemic years. And bariatric surgery, 21 procedures were done in the pre-COVID timeframe, and only 5 were done in the post-COVID timeframe. Also interesting to note that no public hospital bariatric surgery was conducted from May 2021, well, I say until February 2022, but we really have only just reintroduced those procedures. Next slide, please. So the number of new enrolments, there's currently over that 4-year period, 399 patients were enrolled. 283 of those patients were enrolled in the pre-pandemic timeframe. And in the post-pandemic, or the 2 years during the COVID experience, 116 were enrolled in the program. The age of the new patients being enrolled is now significantly lower, and the weight and BMI significantly higher. Next slide, please. So, in summary, the changes imposed on this outpatient service to accommodate COVID-19 restrictions resulted in significant changes, including an almost 60% reduction of patients being able to be enrolled in the program, which resulted in the waiting list of referrals more than doubling. The new patients being enrolled were younger, with higher baseline weights and BMI, and there was also a 75% less access to bariatric surgery. Next slide, please. So in discussion, the COVID-19 has resulted in significantly reduced access to care for the very group identified as high risk for poorer outcomes with COVID-19. And a higher acuity of patients have been enrolled and are being managed in the program without the clinical staffing levels being returned to their pre-pandemic levels. Yeah, have I got any questions? No questions?
Not that I can see,
Yeah. Not much time to develop them, really.
So, Kathy, I think that fantastic presentation. It's interesting to see how you've quantified the impact of COVID on a service. Any idea how long it would take to catch up? Is there a plan for how you're going to address that going forward?
Well, we are trying to get our staffing levels back to pre-pandemic levels. That will be a good start. That primarily relates to the exercise services that we provide. We have started recruiting a lot more patients to the program. That's through we provide an introductory group session for people, and obviously we can't have large groups as we did pre-pandemic, but there is a plan. We're trying to get on top of it.
Yeah, so there is one question. It's how to anticipate proceedings so further outbreaks don't interrupt service so much.
Say that again. How do
you anticipate proceedings so further outbreaks don't interrupt service so much?
Not really. We didn't anticipate this first one, and it's not something I have a great deal of control over. But we do our best in trying to support those. We have had a lot of referrals, particularly from respiratory, who have obviously had patients that were very difficult to nurse through, and we are trying to prioritise patients that really need our assistance.
Excellent. Thanks so much, Kathy. In the interest of time, I'll move on. Dr. Archit Chawla will also be following up with a presentation regarding post-COVID-19 follow-up at Campbelltown Hospital.
Thank you very much. So my talk is on the experience of the post-COVID-19 follow-up clinic at Campbelltown Hospital. I'd like to acknowledge Dr. Deepak Bonagiri, an intensivist, Graham Thompson and Sue Fu for their contributions towards this talk. Next slide, please. So as a bit of a background, COVID-19 infections have obviously created a high frequency of numbers of infections, especially since the July outbreak of Delta and subsequent by Omicron. And at least in the Southwest Sydney Local Health District, we've had a significant number of hospitalizations, which have created obviously a significant burden on the acute medical services, as we have been hearing within the local health district. A proportion of these patients have been experiencing severe or critical infection, requiring admission to the intensive care. And these are the patients who we often think will have poorer outcomes overall and have prolonged, protracted symptoms which may need follow-up. At the present time, there is no formalized multidisciplinary or integrated service for follow-up of these patients. All the patients have been asked to follow up with GP or relevant specialists as required. The Campbelltown Respiratory Department have set up a post-COVID clinic from November of 2021 as part of post-acute care in order to ensure most severe disease, including those patients with the requirement for intensive care admissions or those with severe hypoxia or non-invasive ventilation, have had some access to medical care. My talk is with regards to doing a QA project as part of an assessment of this COVID follow-up. Next slide, please. So the aims and objectives of our data collection has been to identify the proportion of patients with ongoing symptoms or illness at the time of follow-up, clarify the nature and severity of ongoing illness, assess the proportion of patients who require further referrals and management, and identify the typical resources that have been utilized in follow-up care, as well as hope to guide the medical community of potential models of care that could be used as ongoing follow-up for these patients within the local health district. Next slide, please. So patient data was collected predominantly from this COVID-19 follow-up clinic. Patients were recruited into that COVID-19 clinic from GP and specialist referrals, but predominantly from an ICU patient database for patients admitted to the intensive care at Campbelltown Hospital. Patients included from this study were from July to October last year, and data was collected predominantly from electronic medical backgrounds. Patients included in the study were aged 16 years and over, with admission to Campbelltown Hospital and predominantly requiring non-invasive ventilation, intubation, or intensive care admission. Next slide, please. The COVID-19 follow-up clinic model at Campbelltown has included follow-up arranged predominantly as an initial telehealth appointment, and partly this was due to the restrictions of patients being able to come into hospital, and generally around the 3-month mark. And the 3-month mark had been chosen partly because the clinic was commenced roughly 4 months after the initial admissions at Campbelltown, but partly also some guidelines, including the ACI guidelines, that suggested the optimal time, maybe somewhere between 6 weeks and 3 months for follow-up post-admission. Patients underwent a semi-structured interview that included questionnaires for ongoing symptoms and disability. This is through the post-COVID-19 functional status scale, as well as the Yorkshire Rehabilitation Scale, which is, both of these scales are validated for use in COVID-19 follow-up. We also collected data regarding pre-admission as well as current vaccination status, as well as any further contact patients may have had with medical services and the nature of any ongoing interventions that they may be undergoing. We also collected data on what services the clinic provided, including further investigations, change in medication therapy, recommendations for vaccinations, recommendations for further therapy, including pulmonary rehab, as well as recommendations for specialist follow-up. The COVID-19 clinic was not designed to follow up patients from start to the end of the illness, but rather in order to triage and make sure that patients had adequate follow-up arranged. And if there was significant burden of disease, then the natural progression was to recommend a specialist follow-up. Next slide, please. So looking at the results that we have collated so far, during the periods of July to October last year, the intensive care admissions were 95 patients. Of these, 20% of all patients required inter-hospital transfers, and this is predominantly for intubated patients or patients who needed ECMO, which were not offered at Campbelltown Hospital. 25%, so 1 in 4, essentially passed away, either in ICU or post discharge to the wards of these 95 patients. Now, Table 2 looks at follow-up statistics from COVID-19 clinic. So out of these 95 patients, 68 had appointments booked so far. Again, a significant proportion had either passed away or from networks outside of Campbelltown. Of these, several did not attend, but from the data collected, the median age of patients was 56 years, slightly more predominance of male participants. Of these patients, 87% had had GP follow-up by the time of their appointment at COVID-19 clinic, which was roughly 3 months after discharge. Roughly 35% of patients had had some sort of specialist follow-up arranged. Either 15% had already attended or 20% were booked. Of the people who were admitted to Campbelltown Hospital intensive care, 30% were vaccinated at the time of their initial illness and 70% were unvaccinated, and 30% was single vaccination only. By the time of follow-up, only 25% had been double vaccinated by that point in time. Another 20% had their vaccinations booked, and 45% were yet to book. Overall, 10% of all patients refused any vaccinations. Next slide. Table 3 looked at ongoing symptoms of our patients. Now, at the roughly 3-month mark, 90% of all patients addressed from this clinic had ongoing symptoms. Although looking at severe symptoms, that was a smaller proportion of all these patients. Roughly about 10–11% of patients still had ongoing severe symptoms, whereas the rest had marked recovery. So what kind of symptoms did they have? Mostly dyspnea and fatigue, as has been documented in literature. Generally, by the 3-month mark, fatigue tends to be the more common symptom, which is not what we found. And one reason might be that we're looking at a focused population of patients who are specifically admitted into the intensive care with severe or critical pneumonitis. So dyspnea as their main symptom was not surprising. 78% of patients still had ongoing dyspnea at the 3-month mark. 3% of patients were still on home oxygen. The range of severity of dyspnea ranged from 1 out of 10 to 10 out of 10, 10 being the most severe dyspnea and 1 being minimal dyspnea. But the median was around the 3 out of 10 mark. Fatigue, 63% of patients had fatigue at the 3-month mark. Again, there was a significant range, although the predominant number of patients had mild levels of fatigue left at that point in time. Other symptoms included weakness. The most patients with weakness had already attended rehabilitation. 50% of patients admitted into the intensive care had significant weight changes, including anywhere from 8 to 40 kilos of weight loss during their hospitalization and post-recovery. A significant proportion admitted to cognitive impairment, brain fog, as well as a mental health impact. Other symptoms included chest pain, hair loss, loss of taste, sexual dysfunction, sleep abnormalities, and quality of life. Next slide, please. And lastly, the clinic interventions included vaccination advice, follow-up investigations, recommendations for referral to specialists, in addition to those who were already referred to specialists, and a repeat appointment was organized for several patients. Next slide. My final comments would be that the COVID-19 clinic experience provided that most patients still had residual symptoms, although these were minor. But there were some patients who had no follow-up with GP or specialist. Most of these had complete resolution of symptoms. And most patients with severe symptoms had already made contact with a GP or specialist. The COVID-19 follow-up clinic did provide interventions. Most of these were regarding vaccinations as well as facilitation referrals. Next slide. Limitations of the study was this was a small cohort of patients and results cannot be applicable to all hospitalizations. Our timings were restricted and we had limited access to data of patients transferred out of hospital. The telehealth nature of this clinic limited clinical examination. However, that was the restrictions of COVID-19 at the time. And lastly, there are models of care that have been developed in Australia and outside. And I think what our clinic has shown is potentially that an earlier follow-up may be beneficial for patients. Although some of these screening questionnaires may be able to be done by allied health and then triaged into appropriate physicians. For the more severe patients, multidisciplinary team input would be useful, including meetings between rehab, immunology, respiratory, allied health. And internal referral pathways for coordinated care would be useful because a lot of these patients have required significant input from not only from the main specialties, but also endocrinology, renal physicians, cardiologists. Thank you. Would I have any questions?
Yeah. Thanks very much, Dr. Chawla. That was excellent. I mean, it really highlights the benefits of vaccination and the serious lingering side effects people are having from COVID. There aren't any questions submitted at this stage, so we might just move on to the next presentation, but please feel free to submit questions and they can be directed to the presenters to follow up on. So thank you again.
Thank you.
So final presentation in this section is Dr. Miga Babde, who is a previous Campbelltown JMO, I think currently working elsewhere at the moment, talking about a retrospective analysis of trends in hospital admissions in patients with cirrhosis in the Macarthur region. So over to you. And this was done in conjunction with Dr. Priya Acharya.
Thank you so much. Good afternoon, everyone. My name is Megha Varvade, and I've had the pleasure of working with Dr. Acharya and her team on this study, which looks at the trends, hospitalization trends of liver patients with cirrhosis in the Macarthur region. Next slide, please. So liver disease, especially in the decompensated state, has a significant global burden, accounting for 2 million deaths a year worldwide. And within Australia is amongst the top 20 leading causes of mortality. Chronic hepatitis B and C, alcohol, as well as non-alcoholic steatohepatitis are the leading causes of cirrhosis worldwide. And in Australia, hepatitis C, closely followed by alcohol, are the top 2 causes. And this is important because both of these have a scope of intervention at the public health level. In keeping with global trends, people from a low socioeconomic background, as is represented heavily in our Southwest Sydney population, as well as Indigenous populations, are disproportionately affected by cirrhosis. Data is lacking about hospitalization trends with cirrhosis patients in the Macarthur region, And our research aimed to address this with a view to better inform allocation of resources and improve health outcomes for these patients. Next slide, please. So our study is a single center retrospective study based at Campbelltown Hospital. We looked through the electronic medical records of patients in the 5-year period between 2015 and 2020 for patients who had diagnostic codes and procedural codes for advanced liver disease and cirrhosis. So as you can see on the slide, we tried to capture, maximize the number of cirrhosis patients we were capturing with our diagnostic codes. And only patients who had objective radiological evidence of cirrhosis were considered for further investigation. Next slide, please. So for patients with cirrhosis, we went on to gather more information from their electronic records, and we analyzed this using Excel. This information included demographics, including age at first presentation and last follow-up, their gender and whether they were of an Indigenous background, the underlying cause of their cirrhosis and its severity, which was assessed using the Child-Pugh score, if they showed complications of decompensation, the number of hospitalizations and the length of stay every admission, and the treatment they received, not only medical and interventional, but the use of allied health services and the use of palliative care services for patients who unfortunately passed away from their liver disease. Next slide, please. So the diagnostics related gave us around 560 individual data files. Today, I'll be presenting an interim analysis on 200 of these patients as we continue to mine through the data and extrapolate trends from the rest. So of the 200 patients, 67 patients had evidence of cirrhosis. And in keeping with global trends, there was a male predominance affecting 43 males versus 24 females. Also in keeping with other studies within Australia, mainly done at Queensland, we could see that the Indigenous population was overrepresented, making up 5% of our cirrhosis patients, while actually accounting for 1% of the Southwest Sydney population. The median age at first presentation was 60 years, and this delay could be accounted for the fact that compensated liver disease is often asymptomatic until decompensation occurs. As you can see in the pie chart, alcohol and NASH were the two leading causes of cirrhosis in the Macarthur region. And around 20% of people had a combination of etiologies contributing to their cirrhosis, where at least one of them was attributed to alcohol or NASH. Other causes included hepatitis C and autoimmune hepatitis. And there was a subgroup of people who had radiological evidence of cirrhosis, but there wasn't sufficient information on their electronic inpatient medical records to determine the exact cause. Alcohol and hepatitis C were the predominant cause in a younger population aged below 50, whereas NASH was more common in the older population. Next slide, please. So the median Child-Pugh score for these patients at presentation was 8. And unfortunately, in nearly half these patients, it worsened over the 5-year period. It stayed the same in 16 patients, and it improved in 17 patients. And that could possibly be accounted for by the fact that they received medical intervention. Just the natural progression of the disease, possible non-compliance and adherence with treatment and follow-up, as well as ongoing hepatic insults could be a couple of reasons that could explain the worsening of their Child-Pugh scores and readmissions for liver-related disease. So 22 of the patients had readmissions over the 5-year period for their liver-related disease, with increasingly prolonged stays with every admission as well. Alcohol was shown to account for more severe cirrhosis in the patients, and almost all patients, around 75% of them, received allied health input, with dietetics and physiotherapy being the main services that were used most commonly. And this is really relevant because we aim for these patients to have a high calorie, high protein, low fat diet, and also address the sarcopenia and malnutrition that goes along with cirrhosis. Unfortunately, 23 patients succumbed to their disease, but a majority of them were referred to palliative care. Next slide, please. So our interim analysis shows that alcohol and NASH are the main cause of cirrhosis in the Macarthur region. And it's predicted that NASH will surpass hepatitis C as well as alcohol globally as the leading cause of cirrhosis, especially in high-income countries where there's increasingly improved access to antivirals, as well as the pandemic of obesity and metabolic syndrome. it's really promising that the morbidity and mortality from all the main causes of cirrhosis are either preventable or modifiable if treated at an early stage. And this is where it links back to our previous speakers, where there needs to be a collaboration between mental health, drug and alcohol, GP, allied and Aboriginal health services to really identify patients who are at risk early before this disease gets to a decompensated stage. Next slide, please. So this is the first study to analyze trends in cirrhosis patients in the Macarthur region. It's a relatively inexpensive study design with EMR providing a wealth of easily accessible information. And so this study has a potential to be replicated at other sites in our local health district and beyond. It would be interesting to investigate the factors that contributed to the worsening and improvement of the Child-Pugh scores and incorporate them in further management, and also to gather information on the economic status of these patients and see how that's impacting health outcomes and if it mirrors trends elsewhere. While our study was limited to inpatients, where they often present with decompensated disease and at a stage where treatment options are limited, it's actually at the outpatient setting where there is a scope and window of opportunity for intervention. And we really hope that our research is able to inform better allocation of resources for earlier detection, intervention, and closer follow-up to improve health outcomes in these patients. Thank you.
Thanks so much, Dr. Vaporized. It's a really interesting presentation, again, highlighting really the multidisciplinary nature that we can't just look at diseases in isolation. There are a number of factors that contribute to the disease state. We need to move on in the interest of time, and we're now moving to the rapid fire presentations. These will be short, sharp, 3-minute presentations. There unfortunately no time for asking questions during the presentations, but please feel free to write your questions in the chat and comments, and we'll endeavour to respond to those. So the first person up is Juniper Cheng, who's from Western Sydney University. Just moving. The challenge for the presenters, but also the technical support.
Hi everyone, I'm Junie. I'm one of the medical students from Western Sydney University. So I'm presenting on non-small cell lung cancer and immunotherapy, and I'd like to acknowledge all of my collaborators who are listed on the slide. Next slide, please. Thank you. In the last 2 years, something many of us have become accustomed to is wearing a mask. So having half of your face covered can make it difficult to recognize you. But once you take off the mask, facial recognition becomes easier and more accurate. Using this analogy, some non-small cell lung cancer cells use a high expression of PD-L1, a protein that marks a cell as self to the immune system as a mask to protect itself. Rather than protecting itself against COVID, the mask conceals the cancer cells from the immune system. Use of immunotherapy in high PD-L1 expressing non-small cell lung cancers allows for demasking of the cancer, which allows the immune system to identify and eliminate these harmful cells. So randomized studies have demonstrated superior overall survival of pembrolizumab and immunotherapy, both alone and in combination with chemotherapy over chemo alone in patients with PD-L1 50% or greater advanced non-small cell lung cancer. Next slide, please. So in this Australian-based retrospective cohort study, we reviewed the real-world outcomes of patients from 3 Sydney hospitals diagnosed between January 2016 and July 2021 with high PD-L1 expressing advanced non-small cell lung cancer who received either first-line pembro and chemo or pembro alone. Of the 111 eligible patients, 25 received pembro with chemo and 86 received pembro alone. The median age at diagnosis was 64.8 years for the combination group and 70.9 years for the pembro-only group. Next slide, please. After a median follow-up of 15.7 months, overall survival was not reached in the combination group versus 15.6 months in the pembro-only group, with a hazard ratio of 0.57. Median progression-free survival was 12.4 versus 9.5 months in the combination versus pembro-only group respectively, with a hazard ratio of 0.62. Objective response rate was high in the combination group at 60% versus 30.3% in the pembro-only group, and younger patients who received the combination therapy had a longer average overall survival. There were more hospitalizations in the combination group at 28% versus 18.6% in the Pembro-only group. However, immune-related adverse events were similar at 32 and 32.6% in the combination and Pembro-only groups respectively. Next slide, please. So in conclusion, findings from this study demonstrated that in patients with PD-L1 50% or greater advanced non-small cell lung cancer, the addition of chemo to first-line pembrolizumab yields a higher objective response rate, but no additional benefits in overall survival or progression-free survival. Furthermore, while overall survival may be improved in younger patients receiving the combination therapy, higher rates of hospitalizations associated with this therapy should warrant caution. Thank you.
So the next, thanks so much, Judy. Really impressive presentation. Continuing on the theme of oncology, we now have Dr. Andrew Clarkson, who's with us as a medical oncologist.
Thanks, Annette. So I'll be presenting on real-world characteristics and outcomes of potentially resectable oligometastatic colorectal cancer. I'd like to acknowledge my co-authors. Next slide, please. So traditionally, treatment for stage 4 colorectal cancer is with palliative intent chemotherapy, but more recently, we've had a trend towards considering patients with oligometastatic disease or a small number of metastases for a definitive resection of metastases for long-term disease control. And this is becoming a common management dilemma in MDT meetings, particularly because there's no real consensus of what constitutes resectable metastatic disease. And some of these patients are truly in this gray zone where they have a borderline, potentially resectable metastases or metastases. And these patients often will have chemotherapy first in an attempt to downstage their disease. And will only go on to have surgery if they have a good response to treatment. Next slide, please. So the aim of our study was to investigate the characteristics and survival of a real-world cohort of stage 4 colorectal cancer patients classified by MDTs as having potentially resectable disease, having curative intent treatment, and entered into a national database where 30 participating Australian sites, including Campbelltown Hospital, prospectively collected and entered patient data. 362 patients were identified as having curative intent treatment with potentially resectable disease, should they have a good response to chemotherapy treatment. And of these patients, 191 patients, or 53%, ultimately had their metastases resected. Next, please. Overall median age of potentially resectable patients was 61 years old, 57% of patients were male, 43% were ECOG performance status greater than or equal to 1. And patients that underwent resection ultimately were likely to be younger, have less comorbidities, and have liver-only metastases. Next, please. The majority of patients received oxaliplatin doublet chemotherapy. Those that underwent surgery had 1 to 2 metastases resected. And for those that underwent surgery, most had an R0 resection. Next, please. And after controlling for other variables on multivariate analysis, potentially resectable patients with liver-only metastases who received aggressive triplet combination chemotherapy remain predictive of undergoing a resection. Next, please. So at the time of data cutoff, the median overall survival was 24.9 months in those who did not undergo resection of metastases, and 51.8 months in patients who did undergo resection of metastases. And after controlling for other variables, resection of metastases was the only factor that remained predictive of better survival, and a predictive of poorer survival were those patients with right-sided primary tumours. Next, please. And so therefore, in routine care, this is a real-world Australian cohort. Over the half of the patients identified as having potentially resectable metastatic disease treated with curative intent ultimately underwent a resection, and those who underwent surgery had a median overall survival of approximately 4 years. This is a heterogeneous patient population, really difficult to study in randomized trials. And our study highlights that for this cohort of patients, that there is a need for continuous assessment of each individual patient on a case-by-case basis at MDT, and not just at initial presentation. Our study does have a number of limitations, and the management of oligometastatic disease is still very much an evolving space, lots of unanswered questions. And so there is a need for ongoing research, particularly with biomarkers of determining who should undergo surgery, and a lot of clinical pathological factors such as the use of circulating tumor DNA to help guide treatment and for long-term prognostication of these patients. Thank you.
very much, Andrew, for that very elegant presentation. Moving right along, next speaker is Ritesh Chimoria from Western Sydney University.
Thank you, Ellie. Good afternoon, everyone. I'm Dr. Ritesh Chimoria. On behalf of our team, I'll be presenting the finding from Direct Australia Type 2 Diabetes Remission Service. We sought to evaluate the effectiveness of 12-week total diet replacement intervention. Next slide, please. A total diet replacement program for people with recent onset type 2 diabetes was initially done in primary care in the UK. In the diabetes remission clinical trial or direct study, almost half of the participants achieved diabetes remission, which is defined as HbA1c below 6.5% of all glucose lowering medication for at least 3 months. Our study aimed to evaluate the translation of the direct intervention in an Australian primary care setting. All patients enrolled in the Direct Australia Type 2 Diabetes Remission Service in southwestern Sydney were included. The intervention was total diet replacement of 850 kilocalories per day for an initial 12 weeks, followed by food reintroduction and weight maintenance up to 52 weeks. The eligibility criteria for the study participants were 80 to 70 years of age, with type 2 diabetes diagnosed for less than or equal to 6 years, not on insulin, and body mass index equal to or greater than 27 kilogram per meter square. The major outcome were weight reduction, improvement in HbA1c, and reduction of diabetes and hypertension medication. Next slide, please. So far, the recruitment has completed with a total of 39 participants, with 32 participants having completed the 12-week total diet replacement intervention. General practices involved in this project size ranged from solo practice to a large practice with 40 GPs, and most practices had a nurse. The table presents the baseline characteristics of all 39 participants. The findings presented here are for the data collected at baseline and following 12 weeks of total diet replacement intervention. There was a significant weight loss of around 12 kilograms and significant reduction in HbA1c of about 0.9%. Moreover, 80 to 90% reduction in diabetes and hypertension medication were observed. The proportion of participants meeting criteria for type 2 diabetes remission was 88% at 12 weeks. Next slide, please. So the take-home message is that a 12-week total diet replacement intervention can be successfully run in Australian primary care setting, regardless of the general practice size. Following the 12-week total diet replacement intervention, there was a significant weight loss, significant reduction in HbA1c, and significant reduction in diabetes and hypertension medication. Finally, these results may guide the development of a framework for a structured type 2 diabetes remission service in an Australian primary care setting. Thank you. I'd be happy to take any question in chat box.
Excellent. Thanks very much, Dr. Chimoria. I just moving to our next presentation. It will be by Slavika Kristik, who's a CNS in community health.
So thank you. So my presentation is about implementation of routine height-and-weight screening in clinical services. Next slide, please. So a little bit of the background. Back in 2015, the Premier had put out the priority to reduce the childhood obesity by 5% by 2025. So what that meant for HELP is that we needed to implement routine screening of heights and weights across all services that see children. So we're not just talking about doctors and nurses doing this, we're actually asking all health professionals that come in contact with children to assess their heights and weights, provide the advice to the family, and also refer them to appropriate service if required. So you can only just imagine the challenges some of the clinicians and some settings may have in order to embed this into their daily practices. So what we did is provided some multiple strategies in order to equip the clinicians to embed this into daily practices. And this included education and training to staff, providing them with the equipment, weight station setup, allocating champions, doing some audits, regular feedbacks, and many, many other strategies. So the purpose of this research was then to evaluate those strategies strategies that we used to see what was working, what was not working, and at the same time to assess barriers and enablers in this implementation and assess the weight bias among the healthcare professionals. Next, please. So we did this through a survey. We asked all staff that participated in a training to complete a 15-minute survey asking about their experiences and their feelings about this implementation. And then we also looked into the sites that did really well. They did really well in this implementation and sites that didn't do so well, and just wanted to see what characteristics they had. Next slide, please. So what we found is that overall education, setting up the weight station and providing the resources were the most useful strategies in this implementation. But what we also found is that the sites that did really well in this implementation were the ones that had mostly nursing ratios, were predominantly pediatric focused sites, and implementation at these sites was driven internally through the champions and coordinators and educators, whereas the sites with the low implementation had an external kind of been externally driven by policies and directors. The sites that did really well also had a more positive cultures and attitudes towards the implementation, and they also use most of the strategies that were provided to them. Next, please. So from this study, we could conclude that in order to implement routine screening successfully across the healthcare settings, we need to have as many strategies as possible. We need to have a coordinator, a key coordinator and a champion to lead this change. We need to provide the staff with the education, with the right equipments and resources, and also just one-off session was not gonna assist the implementation. We need to provide a continual refreshers and training. But the biggest highlight of this study was despite all this training and implementation, the clinicians still carried significant amount of weight bias, which we know may have influenced the implementation success. And for that reason, addressing the weight bias is essential in healthcare. Next slide is just the acknowledgement. Thank you.
Thank you very much, Sarika. Our next presenter will be Quinn Jiang from the Metabolic Rehab Service.
Hi everyone, my name is Quinn. I'm a general medicine advanced trainee, and this study is looking at activity levels in adults with class 3 obesity enrolled in a multidisciplinary weight management program. Next slide, please. So according to self-reported data, over half of all adult Australians do not participate in sufficient levels of physical activity according to Australian guidelines. And for this, for adults aged 18 to 64, this constitutes 150 minutes of moderate to vigorous activity per week. In the setting of severe obesity, there are even more limitations imposed on their ability to complete exercise. This study aims to quantify the reported weekly activity levels of people with class 3 obesity, and also aims to assess any changes in their activity level after participating on a multidisciplinary weight management program for 6 or 12 months. In this study, we included all adults with BMI greater than 40, who are enrolled in the Southwestern Sydney Metabolic Rehabilitation and Bariatric Program run from Camden Hospital between 2017 and 2022. Their activity levels were assessed using the International Physical Activity Questionnaire, or the IPAC. Next slide, please. Of all the participants that were enrolled, 230 had completed the IPAC at baseline. Table 1 shows their basic demographics at baseline. So their average age was 48.2 years, and there was a female predominance and a Caucasian predominance in the participants. The average weight was 151 kilograms of all the participants, and their average BMI was 53.3. On enrollment into the program, 57% of them did not do any moderate or vigorous activity, and the breakdown is 19% did no activity at all, and 38% did walking only. And calculating the total duration of moderate to vigorous exercise, only 27% of the participants did sufficient amount of physical activity according to the Australian guidelines. And this is shown in figure 1. Figure 2 shows comparison between initial total duration of exercise compared to follow-up total duration of exercise at 6 or 12 months on the program. And there was no significant to total durations. So there was no significant increase in total exercise duration after participating on the program for 6 or 12 months. However, there was a significant weight loss after the participants had participated for 6 or 12 months, with an average weight loss of 5.9% or 4.3% of total body weight. Next slide, please. Because this study relied on survey data, which was self-reported, there may be over or underestimation activity level due to recall bias. Some of our was also collected during the COVID-19 lockdown when supervised exercise programs were closed. So this may have led to lower reported activity levels in some cases. But overall, this study concluded that people with class 3 obesity have lower than recommended levels of activity, with only 27% doing sufficient levels of physical activity according to Australian guidelines. There was no significant change in the total exercise duration after 6 or 12 months on the program, but in spite of no changes in their activity levels, there was still significant weight loss achieved whilst on the program. Thank you.
We're still shocked by the mean BMI on that slide. Next up is Dr. Ben Newman from Respiratory Medicine.
Thank you, and thank you for giving me the opportunity to present the study that I was involved with Dr. Belinda Cochrane when I was an advanced trainee at Campbelltown, entitled The Oxygen Project. Next slide, please. So oxygen therapy is commonly used in the care of acutely ill patients. However, it is sometimes inappropriately used, and this can have negative implications for such as life-threatening hypercapnic respiratory failure in susceptible individuals. There are a number of professional bodies that advocate that a prescription of oxygen should be provided using target saturation ranges. However, this is poorly adhered to in the studies. Next slide, please. The aim of our study was to determine the baseline oxygen prescribing practices at Campbelltown Hospital and to explore whether a targeted education program intervention could improve clinical practice. Next slide, please. This is a flowchart of our study. We initially conducted a preliminary audit to identify the wards in which oxygen was most commonly used, and this was found to be the respiratory, oncology, and surgical wards. We then collected baseline data on oxygen prescription, administration, and monitoring practices. We then implemented an education program about the safe use of oxygen targeted towards nursing staff and junior medical staff. We then assessed the effectiveness of the intervention by repeating our data collection at 3 months and 6 months post-intervention. Next slide, please. We found that overall, there was a trend towards increased oxygen prescriptions at 3 months and 6 months post-intervention, and this was driven by the medical wards, with the respiratory ward demonstrating a significant and sustained increase in oxygen prescriptions at 3 months and 6 months. And on the oncology ward, there was a significant increase initially, but this was not sustained at 6 months, and there was no significant changes on the surgical ward following the intervention. Of the patients who were on oxygen and had their oxygen saturations that were outside of the target range, none of them had their oxygen therapy adjusted. Next slide, please. So in summary, our study shows that an education program directed at nursing and junior medical staff on the safe use of oxygen can significantly improve the documentation of oxygen prescription on medical wards. However, this was not seen on the surgical wards, where alternative strategies may be required. Concerningly, patients who were on oxygen therapy and had oxygen saturations outside of their target range did not have their oxygen therapy adjusted, which potentially places these patients at risk. And this highlights the need for us to continue to develop strategies to improve oxygen management in our hospitals. Thank you very much.
Thanks, Ben, for a nice succinct presentation. And next presenter will be Dr. Jim Taylor from the Geriatrics Department.
Hello, everyone. Thank you for giving me the opportunity to attend the rapid oral presentation. So my presentation is part of my advanced training project that was done here in 2019 in Campbelltown Hospital, looking at how the risk factors that's commonly found in geriatric population affect the length of stay. Next slide, please. So patients with geriatric syndromes account for quite a significant proportion of patients admitted to Campbelltown Hospital, and prolonged length of stay, which is defined in this health area network as more than 9 days, is associated with increased complications for patients, shortage of hospital beds, and increased healthcare costs. Unfortunately, risk factors for length of stay is different across every hospital, and I'm interested in knowing locally in Campbelltown what are the risk factors that affect length of stay. Next slide, please. So the study itself is a single-center retrospective cohort study. We sample patients that came in that's aged above 17 and above. They came in under geriatric medicine service in Campbelltown Hospital between April 2019 to July 2019, and we divided them into 2 groups based on length of stay, one less than 9 days and one equal or more than 9 days. And in total, we had 482 patients, and we excluded patients who come from an aged care facility and those who's coming in for purely comfort measures only. The 10 common risk factors that we chose was age, gender, history of falls in the preceding 6 months, presence of high-risk medication that's defined as per the Beer criteria for high-risk medications, presence of cognitive impairment based on a diagnosis by the medical team or previous mini-mental MOCA or RUDAS score, presence of care stress and or burden documented by medical team or the social allied health input, presence of delirium, previous admission in the past 3 months, need for ICU admission during the stay in hospital, and presence of or at risk of frailty, and that's defined by the Canadian frailty scale of more than 4 and above. And the primary outcome that we're interested in is basically how those 10 risk factors affect the length of stay of the patients. And the secondary outcome that we're interested in is how are those patients with prolonged length of stay, how is that impacted on the hospital-acquired complications, which is delirium, falls, infection, pressure area, injury, and mortality. Next slide, please. So it's kind of our demographic result of our patient sample size for that 3 months. In average, our patients stay around 10.3 days. However, if we divide them into 2 different groups, if they are in for less than 9 days, normally they get discharged within 4 days, around 4 days mark. However, if they have to stay more than 9 days, then their length of stay increases to 19 days. The age is quite similar between the 2 groups, which is age 3.1. We have more predominant female population coming in under our admission. And 1/3 of our patients has delirium, 3/4 of our patients has frailty, and almost 90% of our patients has at least 1 high-risk medication on board. 30% of our patients has cognitive impairment. I suspect that this is probably underestimation of due to the way we capture our data. And 1/3 of patients has care, stress, and burden. Next slide, please. So when we did logical regression of our result of our length of stay compared to the risk factors, what we found was only 3 things that are significant in that female gender makes you more likely to stay in hospital and have longer length of stay. Care, stress, and burden, which is the most significant relative risk with a relative risk of 5.2. as well as frailty. So all those 3 factors are, I guess, significant in predicting length of stay. Next slide, please. Yeah. So I guess for hospital-acquired complication, it's really Also for length of stay, respiratory pressure area in hospital infection and delirium that's significant. The longer you stay, the more significant, the more high chance that you acquire those. So next slide. So in conclusion, frailty, female gender, care, stress, and burden are significant risk factors for prolonged length of stay in Cape Town Hospital. And we hope that by identifying this, we can create a prospective screening tool that will help us with helping patient flow for locally in Cape Town Hospital. Thank you very much.
Great, thanks, Dr. Teo. And our final oral presentation is by Dr. Javeria Jamal from cardiology.
Okay. Hi, everyone. Today I'm Javeria, and today I'd like to discuss with you late outcomes of 2 guideline recommended reperfusion strategies that we use for managing STEMI based on data that we've obtained from just over a decade across our district. So we know that primary PCI is the most common reperfusion strategy for the, next slide please, yeah, for the management of STEMI. And according to guidelines, it's the default strategy provided that it can be performed within 90 minutes of first medical contact. But it's often the second part of the sentence that people forget, in that when primary PCI can't be performed within this tight time frame, fibrinolysis is the strategy of choice in the absence of contraindications. So achieving timely primary PCI remains a challenge. There's a number of geographical and logistical considerations that sort of impede getting primary PCI within that time frame. So a large proportion of patients end up requiring something called pharmacoinvasive PCI. Next slide, please. So pharmacoinvasive PCI involves administration of fibrinolysis within 10 minutes of the diagnostic ECG, and then transferring those patients to a PCI hub for non-urgent scheduled PCI within about the 24-hour time frame, and then having a rescue PCI as an invasive backup in case fibrinolysis is unsuccessful. Next slide, please. So what our project did is we looked at STEMI patients who presented to Liverpool Hospital or were transferred from referral hospitals, including Campbelltown, from October 2003 to March 2014. It included a total of over 2,000 patients. About half of them underwent primary PCI, and the other half underwent a pharmacoinvasive approach. And what we found was that within sort of the primary PCI group, about a third underwent late primary PCI, so beyond the recommended timeframes. And within the fibrinolysis group, there was about a third who failed pharmacological reperfusion and then required urgent rescue PCI. We followed all of these 2,000 patients for 3 years post their initial infarct, and then compared outcomes across the 4 subgroups. Next slide, please. So 3-year survival, we found that the group that did the poorest were the group who received primary PCI beyond recommended time targets. They did far worse throughout the entire study period than the pharmacoinvasive group, including the group that failed fibrinolysis and then required urgent transfer for rescue PCI. Next slide, please. So we propensity matched these groups to account for any sort of differing baseline characteristics, and we still found that the late primary PCI group had significantly lower rates of long-term survival compared to patients who received fibrinolysis and then subsequent scheduled PCI. Interestingly, when we compared that scheduled PCI group to timely primary PCI, we found almost superimposed curves. So both strategies, when done correctly, had similar outcomes long term. Next slide, please. So these are just some forest plots comparing both mortality rates and the composite endpoint rates, which was basically a combination of mortality, reinfarction, stent thrombosis, and target vessel revascularization at the 3-year endpoint in 4 of the propensity matched cohorts. And essentially the take-home message is that the group that had late primary PCI did poorer compared to the other 3 subgroups. Next slide, please. So this is really my final point. We also looked at a number of different outcomes across the 4 subgroups, and including things like stroke and intracranial hemorrhage and bleeding. And we found that the pharmacoinvasive PCI group did not do any worse than the primary PCI group in terms of intracranial hemorrhage and bleeding, which is interesting because there are often reasons that clinicians are reluctant to use this therapy. Next slide, please. So in conclusion, timely primary PCI is difficult to achieve for a large proportion of patients, particularly in geographically sparse districts like ours. So realistic assessments need to be made in terms of how quickly it can be performed. And if we expect this to be greater than 90 minutes, a pharmacoinvasive approach should be seriously considered because it has superior outcomes compared to primary PCI performed late. Thank you.
So thank you so much. So I just wanted to say thank you to all the presenters. I mean, it's a hard task to present under these conditions, both virtually and also under tight timeframes. So you ought to all be commended. I think it really highlights the breadth of research that has been undertaken across the hospitals, and I think this has really showcased that really well. We are going to take a 10-minute break and resume at 4 p.m. During that time, you can take a virtual walk through the poster presentations, which will now be broadcast on the screens. I'd just like to say that the presentations, for those that have provided consent, will be available on the website for people to look at and review later. So thank you, and we'll see you all again at 4 p.m.
Good afternoon, everybody. I'm hoping you can hear me. My name is Loretta Anderson and I am the Director of Allied Health across Camden and Campbelltown hospitals. Thank you to all of our presenters and contributors this afternoon. Amazing work and dedication shown in all of our presentations. Certainly let's move forward and grow this research brains trust in South West Sydney. So, welcome to our final 30-minute session on research skills development. The purpose of this final session is to give our clinicians insights and ideas about various aspects of the research process, from literature review, literature searching, applying for ethics, recruiting participants, and engaging with our culturally and linguistically diverse communities in research through to maximising the impact of your research. We have 5 speakers this afternoon. They will each be given the task of sharing their top 5 tips in 5 minutes for an aspect of the research process. First up, I would like to welcome Professor Murray Killingsworth. Professor Killingsworth is the chair of the Ethics Committee here at South West Sydney. So if you could kick us off, Professor Killingsworth, with your top 5 tips for applying for ethics.
Hi, Loretta. Thank you, Loretta, for the introduction. Sorry, the audio is breaking up a little bit. But yeah, look, I'd like to introduce myself. I'm Murray Killingsworth. I'm the current chair of the Human Research Ethics Committee of South Western Sydney Local Health District. And my co-presenter today is Anna Marie de Souza, who is the Research Development Manager based at our Research Directorate, also at South Western Sydney Local Health District. So we have the first slide, please. Okay, so these are our top 5 tips. We'll try and, I think maybe there could be a couple more than 5, but we'll try and get through them in 5 minutes. So I thought the first probably useful tip is for you to consider what actually the role of the ATREC is. And we're aware that you know, applying for ethical review, some people do find a daunting task. So I think it's useful to clarify what we actually are and what we do. Our first job when we would look at your review is to decide, well, is it research or is it quality improvement, quality assurance? Of course, if it's quality assurance or quality improvement, it doesn't need ethical review for research. So that's a decision that's made with a tool we call our decision aid. So if you're new to the applying to ethics, I'd recommend that you fill in one of the decision aid documents to get that feedback before you actually do a full-blown application. The other thing I'd like to reassure you all of is that we are pro-research. We're here to help you get your research implemented as quickly as possible and started as quickly as possible. We support research. We don't really, I think in the last 12 months, we've failed to give ethical approval to, I think, one study. And our other focus is obviously building trust within the research community and within the community in general. We do tend to look at reviews through a patient participant lens, and I guess we're patient participant advocates in that sense. We obviously stand up for participant freedom of choice and options in treatment. We also assess the scientific merit and integrity of your application, and we're aware of risk awareness considerations in any research undertaken in southwestern Sydney. So next slide, please. So our second tip is read the national statement. If you're thinking about putting in a study application for ethical review, have a look at the national statement. It's most important. The first two chapters you'll find the values and principles which underpin ethical research in Australia. This document was put out by the National Health and Medical Research Council. These themes in research are basically commonly known: the respect, research merit and integrity, justice and beneficence. And these apply to all projects we review. And underlying those values are the principles, I guess, which are in the second column here, which are the practical applications of the principles. The later chapters are sort of study specific, and depending on what sort of study you're doing, you'll find guidance on what, whether you're working with vulnerable communities, participants, and so forth. So I recommend that as my number 2 tip. So for our following tips, I'll hand you over to Anna Marie for our following 3 to 4 tips. Thank you, Anna Marie.
Thanks, Murray. Next slide, please. I cannot impress the importance of collaboration. Often when you're thinking of doing your research projects, it is something quite overwhelming, and therefore I would advise all of you to make sure you form a good group around yourselves, people within your team, within your unit, looking at building a multidisciplinary team that will assist you and bring in different considerations to your research project, making sure you also find ways to collaborate with university partners and add some strengths to your research. If you are stuck and unable to identify key people that might be able to support you, feel free to contact our office, and we would be very happy to link you up with the key collaborators that would help make your application stronger. The other thing that you could also do is talk to your supporting departments early on in the planning of your research project. This will help them to identify whether they are able to support your research project, give them some information about what the project is, and this will help you reduce any delays that you might experience into the future. Make sure you talk to all of your colleagues, get them on board, and form a support structure around yourself. Also asking a lot of questions: where, when, why, who, of your research team, of your collaborators, and also of the research office will help you identify some of the key issues that come up later on and help you make that application into a stronger application. Next slide, please. Very important for you to ensure that you leave enough of time to plan for your research project. Our ethics committee can tell when something's slapped together and put together in a couple of days, because it comes out from the quality of the application. I would impress on you to make sure you leave enough of time to plan your research project. Attend any training sessions that are made available. Regis does have quite a few training sessions that are made available on their website, which will help you when you actually start to put in your ethics application. We also have training sessions that our office conducts on a regular basis. We were doing this regularly pre-COVID and are hoping to pick this up again in the coming months. We are also very happy to come out to your sites and talk to your entire team on an ad hoc basis based on your needs and the sessions that you would like us to cover. Another opportunity that we do offer for our community is the ability to attend our ethics committee meetings as an observer. This will allow you to get an insight into the deliberations of the ethics committee, the makeup of the ethics committee, which will then further help you when you are writing your protocol and making your submissions to understand where the committee is coming from, the kinds of questions and concerns that they might raise, and ensuring that you address these prior to even submitting your application. Next slide, please. I made sure I tried to keep it within five top tips. The protocol is the most important document that you will be working with when you are putting in your ethics application. So I would ask all of you to pay attention, treat this as your blueprint, make sure you put in as much information as possible into your protocol to allow the committee to be able to understand what you're planning on doing and to be able to give you some feedback to help make your application stronger and a better application. We do have, in order to assist you with doing this, we do have some templates on our website. Please make sure you use the templates for the protocols, our information sheets and consent forms. These do seem like very simple tips, but I have to let you know that on behalf of the ethics committee, this is really important to us, that you do a spell check, avoid the use of acronyms to help the committee be able to assess your application better, be concise and use lay language. One of the reasons for that is the reviewers on our ethics committee are quite diverse. We have lawyers, lay members, people from a medical background, but from various departments, and it's important that you are able to explain what you're planning on doing in simple language without using excessive jargon. And my last point would be around the fact that even the most established researchers on our ethics committee do receive a request for further clarification from the committee. These are members who are members of our ethics committee and still receive further information requests. So I would say the ethics committee is very pro-research, and the ethics office is here to support you to do your research project. Any further information requests that you receive, we're very happy to work with you to help you do your research in a better way. That's it for me. Thanks, Loretta.
Thank you, Anna Maria. Sorry I haven't introduced you. I'm Professor Killingsworth. Lots to think about there, so thank you for those tips. Can everybody hear me better now?
Still a little bit crackling.
Is that better?
Yeah.
Okay, let me hold this up. I do apologise, everybody. Okay, so thank you to our presenters. I'd like to welcome Judy Reading, our library manager, and Layla Mohammadi, our research librarian here at Campbelltown Hospital, working across both Macarthur and Barrel. Their presentation this afternoon and top 5 tips around making the most of your clinical librarian for research. Over to you, ladies.
Thank you. Could I have the first slide, please? Okay, so basically we have one main top tip, and that is to make sure you take full advantage of the services that we offer you. We can help at every stage of the research life cycle. People often think of us just when they're coming to do their literature review, but we can help at every stage, from formulating your research question and thinking about which areas are the best for which need focusing on, right through to promoting your research and calculating your research impact. We are published researchers ourselves, and we've got extensive experience supporting researchers in universities as well as clinical settings. So we can sort of speak your language and understand what you need. Could I have our next slide, please? Okay, one of the initiatives that we've developed just recently, my colleague Layla has taken the initiative on this particularly, is a new library website, which is designed both to promote the activity of the researchers here in the district, but also as a one-stop shop guidance of what resources are here to support you. So it includes information about grants, conferences, research training and more, and we'll link you to the various organisations, the library, as well as the Research and Ethics Office and others. So hopefully people are aware of this, but it is really going to be very valuable going forward. I'm going to pass over to my colleague Layla, who's the research librarian, who's going to talk about some more specific ways we can help you.
Thank you, Judy. Next slide, please. Hello, this is Layla. I would like to talk about some specific ways that we can support your research project. In regards to grant support and grant applications, we can help you to identify the best 5 or 10 publications according to NHMRC or ARC grant application criteria. benchmark your research against peers in the field, and identify potential collaborators. We can also assist with interpreting research metrics data to show the best of your research output and impact to support your funding applications, and provide some advice on how to plan for managing your research data. Next slide, please. So this is the systematic review support from the library. These are steps involved in conducting a highly sensitive literature searching for systematic reviews and any other literature reviews for publications. We help with both systematic reviews designs as well as literature searching, and as you can see from this slide. We will help with formulating your research question, developing a logic grid, and designing a master search and then translating it into multiple databases. We can also help with exporting citations into citation management systems such as EndNote or Covet, which is another tool to conduct systematic reviews. And we also help with methodology write-up and PRISMA report. Next slide, please. Another service that the library provides is helping with scholarly publishing. This includes advice on what to consider when you want to publish an article, introducing journal selection tools, as well as helping with identifying journal metrics, as well as impact factor. This slide captures one of those journal selection tools called Journal Guide. And as you will see, if you add your or enter your title or abstract related to your manuscript or just a few keywords, the system will suggest you the suggested journals as well as impact factors, who published the journal, is it open access or not, and the time that it takes to publish the papers. Next slide, please. Okay, we can help you to use ORCID to promote your research outcome. ORCID provides a persistent digital identifier unique to each researcher. ORCID allows you to claim and keep track of your research publications. It is really important to register and use ORCID. You will be distinguished from every other researcher, even researchers who share your same name. Your research output, activities, affiliation will be correctly attributed to you, and it improves the visibility or discoverability of your research output. You just need to follow 3 simple steps to register. You need to open, the web page, orchid.org, add your personal data, set up notification, and set up visibility. Next slide, please. So we would encourage you to register for ORCID today if you haven't, and if you have already registered, obviously you can add multiple affiliations into your account, and we would recommend you to add hospital if you haven't already, and we would suggest this format if you wanted to add your hospital affiliation. Next slide, please. So thank you for listening to us, and we're looking forward to work with you. Thanks very much.
Thank you, Judy and Leila. Is that a better sound?
Yes, perfect now.
Much better. Okay.
Much better.
Okay, so sorry about that, everybody. Okay, moving on to our third session. So Meg Ford, we welcome you today, Manager of Clinical Trials with Southwest Sydney and an affiliate of the Ingham Institute. We welcome you. Recruiting participants in clinical trials. Meg's going to share us her top 5 tips. Thank you.
Thank you. So thanks for asking me to join. Recruitment into clinical trials is one of the most challenging pieces of running a clinical trial. When you first look at clinical trials, you always think you've got many patients, but then when we actually go to recruit, a lot of the time you'll find that that's not actually the case. So I guess my top tips sound pretty easy, but they take a lot of work and resourcing. I was going to write plan, and then replan as my 5 top tips, but there are some additional things that I guess I could share with you. planning is probably the most efficient and effective way of looking at participant recruitment. You need a strategy for where your participants are going to come from. What are the barriers that you have to recruitment and how are you going to mitigate those barriers? What's going to help with recruitment? What's going to hinder recruitment? What budget do you have so that you actually have money to spend to bring participants into your clinical trials? And then what kind of third-party vendors could you potentially use? And that's all done as part of a participant recruitment strategy. We do have a template document that you can use to do that. And I highly recommend that when you are looking at a clinical trial, in the very early stages, you do that and you review the protocol, you make sure that you have risk mitigation put in place so that you can actually recruit to target. The global statistics for clinical trials on recruiting to target are pretty appalling, and 80% of clinical trials don't recruit to the initial plan target and timelines, and about 10% of sites never actually recruit a clinical trial patient into a clinical trial, which means that you spend all this time setting up the clinical trial and then you don't actually recruit and you don't actually get paid for the time that you've spent. So that planning up front before you submit to ethics is really, really important. The second tip is to develop appropriate materials that you're going to need for recruitment. Everybody thinks of patient recruitment materials as flyers and materials that advertise your clinical trial and you can promote to patients, but that's not actually all of the materials. And just thinking about it in terms of what Nate said, it's really important that when you are developing your patient materials, that you actually develop culturally appropriate materials. So it's not good enough to just translate a consent form from English into another language and expect that that's going to have the same meaning that it has in English in the language that you're translating it to. So those things are really important when you are doing putting your clinical trial materials together. We highly recommend you have a one-page summary that just gives a really high overview of the clinical trial that you can give to participants. It's pretty overwhelming for people to be handed a 20-page consent form when they've just been diagnosed with a disease or they've been told that they've got an increase in severity of their disease. So that one pager actually helps you to be able to have an initial conversation with patients and participants. What materials do you need for referrals? So are you going to get your patients from GP referrals, from specialist referrals, from physio referrals? What materials do you actually need to develop so that you can actually go out to those people and create awareness of your clinical trial? And then do you need things like social media? Do you want to advertise online? Though all of those pieces need to be really thought through carefully and brought together in an appropriate package prior to you even submitting to the ethics. And the Clinical Trial Support Unit's more than happy to help people develop those materials and with that planning. Recruiting takes resources, and that's one thing that I think people don't underestimate when they're thinking about a clinical trial. How are you going to manage your recruitment activities? Are you going to have a lot of screen failures? So you might bring these patients into the studies, but then they actually end up being screen failures and they don't progress into the study. So those things need to be thought about, and they actually need to be planned for in a budget and made sure that those are being covered. A lot of clinical trials have little hidden pieces in them, like the collaborative group trials or the commercial trials, wanting you to send them every week a screening log. Now, that might sound simple to somebody who's sitting in an office running a clinical trial, but at a site level, that takes resources. So you've really got to think about when you're initiating a study, what are those resources and do you have the money to pay for them, and who are those people?
Meg, can we cover off on the next two as quickly as possible, please?
Sure. Creating awareness of your clinical trial is really important. So who are your internal departments that need to be aware? Who are your external people that need to be aware of clinical trials? Do you need to go out and actually do some selling to people who are going to refer to you? And then monitoring and adapting your plans. So are you meeting your recruitment timelines? What are you going to get per month? If you're not meeting that, how do you adapt that planning and those materials that will actually bring you patients in? And I think probably the biggest thing is you need to be flexible. If you find something's not working early on, change it up because that will increase your participant recruitment into your clinical trials.
Excellent. Sorry to interrupt. Thank you, Meg, very much. Okay, so moving on for the next 5-minute presentation to Dr. Tang, Director of Physiotherapy at Western Sydney, on co-designing research with culturally and linguistically diverse communities. Thank you, Clarice.
Thank you, Loretta, and I hope that everyone can hear me well. Before I start, I would just like to acknowledge the traditional owners of the lands and also pay my respects to the elders, past, present, and emerging. Can I please kindly, in conscious of time, jump to slide 4? Next slide, sorry. Yes, that's right. Thank you. All right, so I'll just start really quickly just to share what experience-based co-design is. We often hear the term co-design often in any kind of research project, but what exactly is experience-based co-design? So in a nutshell, experience-based co-design was actually developed and really heavily utilized in the more recent years in areas such as mental health, cancer care, and also in development of health services and health programs, and involve these 6 key steps as outlined in this diagram. Can I request to jump to slide 7, please? Next slide, next slide. Next slide. So therefore, what are my 5 tips? Thank you. What are my 5 tips when you are thinking about actually doing co-design research, especially with people from Cal backgrounds? Next slide, please. So the first thing is first to determine your research question. What are you actually trying to co-design? Is it a program that you're trying to reinvent, or is it a changing in health model or the service or the way you are delivering a service within the hospital or within the health system? And what are the priorities of the people from the Cal groups, and especially the targeted Cal group that you are interested in? Bearing in mind that every cultural group is actually different, and we shouldn't be actually using a one-size-fits-all kind of approach to bundle everybody from a Cal group into one section. So you do need to realize what are the priorities of these people and how do they fit into your research project. Next thing is really to think about whether, to the previous, never mind. Thank you. Next is to reflect on your own kind of perception and idea, especially towards your target cultural group, and whether because your own perceptions and ideas may sometimes hinder or facilitate the research. My second tip is next slide, please. Sorry. Engage your community. So whenever you're doing actually any types of research with Cal groups, we need to first get the people from Cal groups to be involved. But in order to get to know these people, you really do need to know who are their community leaders, and also engage with multicultural health workers within the health service and also out in the community. You also need to, when you're selling or when you are actually conversing or communicating your ideas about your research project with the community, you need to balance the community needs with evidence-based interventions. So for example, if you are actually trying to implement an evidence-based exercise program, you can't compromise the quality of the exercise program in order to balance that community needs. However, you may redesign certain things like the format of the program or even the type of exercises that are included in the exercise program. And then when you're actually engaging with the community, you need to be explicit in terms of what you expect them to co-design. what cannot be compromised as part of this process, and also your expectations of the participants. Next slide, please. Next, with every experience-based co-design, the spotlight to your research project is actually not on yourself as the lead researcher, but your participants. So you do need to let the participants lead the show. The main role of the researcher is really to set up this skeleton. And when we say set up the skeleton, it really means about firstly outlining what's the aim of the research, but also what are the processes that you are going to use when first to explore and understand the experiences of the people from your target cultural group, and also what format of or how you're going to go about actually implementing or running your co-design workshops. And it leads me to really to think about the format of your workshops, especially when you are working with people from CAL groups that have diverse cultural needs and also language needs. You need to think about things like, do you have enough resources dedicated to language support? Who is going to be the facilitator of the workshop? And what mode of delivery will this workshop be conducted in? Is it going to be a Zoom, a face-to-face, or hybrid? Next slide, please. Fourth tip for everyone is to think about having a community representative to be involved in the governance process. So setting up a clear governance process, including the community representatives in this governance process, and because they do play a key role in the dissemination of information of your project and also in your recruitment of this project. The other thing to really consider, which is something that may be a bit different, is to consider the inclusion of these community representatives in your ethics application and your authorship. And last but not least, next slide, please, is to look at empowering the people. Don't forget, every successful experience-based co-design is only successful because the participants have actually led the entire process. So it's really important that as the lead researcher, you need to think about how you're going to empower the people by making every party feel valued. This can be done through thinking about how you're going to balance those power relationships within the groups and also between the groups, creating a culturally safe environment in terms of, especially when you're working with people from CAL communities. And last but not least, thinking about valuing these participants by providing some degree of remuneration. And in the conscious of time, I will hereby conclude my talk. Thank you very much, Loretta.
Thank you very much, Clarice. Over to you, Professor Baker.
So our final presentation this afternoon before we have our prizes is looking at maximising the impact of your research, both looking at the reach of your research that you've done, as well as maximising your research profile. Next slide, please. So my 5 tips, and I'll do these briefly and have a few slides on each one. Collaborate, and we've had a few of our presenters talk about that. Anna Marie mentioned it, and Chris talked about collaborations to really drive home impactful research. Know your bibliometrics and your altmetrics, make the most of social media and maximise your online profile. So if we take that first point there around collaborate, next slide please. Embrace the opportunities for co-design to find out what is the need and who needs that in the community. Secondly, really seek out established multidisciplinary teams who've been being engaged in your research. If you're a novice researcher, that's a great way to raise your profile fairly quickly, is work with experienced teams. And then finally, find out organisations that share your passion for your topic, granting bodies, organisations and philanthropy. So collaborate. Second, next point, please. Know your bibliometrics. So these are the traditional kind of metrics to look at your impact, your journal impact factor, the metrics on your actual article, like the citation count, as well as your own author metrics, which is now these days referred to mostly as a H index. So that's one, is go and find out what your H index is if you're not aware of it. Next slide, please. As a complement to bibliometrics are altmetrics, and they're they complement traditional biometrics, bibliometrics. Think of them as a digital footprint of your research and what your activity is, your research and your clinical practice out there on the web. Because if you're not aware of it, a lot of your work is actually being spread out there, and you need to take a bit of control of it and manage and curate that.
You can look at the usage of your work, who is engaging with your work, the attention it's receiving, as well as your citations. And there are a lot of different organisations and companies that are making the most of this opportunity to curate this digital footprint by researchers. So there's a few companies, organisations called Publons, another one's called Kudos, another one that Leila referred to before was Orchid. So we just go to the next slide, please. I thought I would focus just on and show you some screenshots that I captured really recently from Altmetrics, and you'll start to see how this digital footprint is being collected by various means that gives you an online profile, and it is being done whether you know it's there or not. So this is a snapshot of Altmetrics of Western Sydney University at the moment. We go to the next shot on the screen. You can then have a look at and find out what is your Altmetrics profile. This is one for Hennessy. We go to the next one. You can even see on that Altmetrics, have a look at where your research is spreading, what's getting the most attention, where it's being picked up. Sometimes it's really quite surprising to think, hey, something's been mentioned in the New York Times, I didn't know that. Next slide, please. You can also track an individual article. So on the top left-hand corner there, you can see the Altmetrics donut, and the different colours there, that you get a score, and then all the different colours show you, if you have a look on the bottom half of that slide there, you see where those colours are coming from, and where your article that might have been published in a journal. So I published this particular article, it wasn't a particularly high impact journal, but it's actually got a lot of traction in the media. And then you can see where it's being picked up across the world. So Altmetrics is a really powerful way, rather than you trying to find all of this out, go to these organisations and companies that actually curate all of that information about you and find out about it. Next slide, please. Another one that's helpful as an organisation for us in South West Sydney is to use VOSviewer. So this is a snapshot of allied health researchers in South West Sydney at the moment, and with using VOSviewer have mapped out, and this is from publications, what their connections are and how their relationships are. Really highlights the value of collaboration. You can see Justine Naylor there is in the middle. She's been researching in South West Sydney for quite some time, and she's got a lot of collaborations with a lot of different people in South West Sydney. So that's another one that's helpful to look out for, find out where you sit on VOSviewer. Next slide, please. For those of you who are not convinced to use social media for your research, hopefully this, and there's lots of articles about this these days, is really valuable. So as an example here from a controlled trial around tweeting, simply tweeting, once you've published a paper, tweet about it. It significantly increases your citation count, and they all feed on one another. So if you're tweeting about it, it's spreading out to more people, they'll see your work, they'll then cite it, and it feeds on itself. So if you don't have a Twitter account, I encourage you to get one. You don't have to spend a lot of time tweeting, just tweeting your articles is enough. To get started, final point is your profile, next slide please, is maximise your online research profile. If you haven't got an ORCID ID today, get one, it only takes a few minutes. If you do have one, go and check that it's updated. Second suggestion will be, and there's lots of different companies that are also trying to curate your research and have a profile already made for you. You want to go and own that and clean it up a bit. One is Publons, that would be a good one. Orchid and Publons talk to one another. The third one is Google Scholar. Again, if you have published anything, you have a Google Scholar profile account, whether you know it or not, it's out there. Go and clean it up and delete some of the articles that have been linked to you, and then go and clean it up so it shows accurately what your research is. You also get to quite easily go and look at what your H index is when you get go and clean up your Google Scholar profile. Next slide, please. If you'd like to know more about this sphere of looking at your digital footprint, about your research, a couple of open access articles there. You can hold your phone up to the screen, and the QR codes there will take you to those. Really helpful. I found those papers really helpful in understanding just that space of, beyond just now publishing the journal, how you really need to take control of how your research is being disseminated. Next slide, please. Final point, remember your research isn't just published, it is spread. I will hand over to you, Loretta, for prize.
Sorry, apologies. Thank you very much to all of our presenters this afternoon. Did you wish for me to proceed to the prize giving at this point, given we're quite a bit behind time? So, prizes. So first of all, please a very sincere thanks to Western Sydney Uni for the sponsorship of our prizes this afternoon. I'm pleased to announce the winners of the poster composition. Best poster with a prize of $200 goes to Drs. Nefeus, Vincent and Jenny for their poster around a novel nanoendoscopy system for the identification of abnormalities in the distal esophagus of chronic reflux patients. So well done to them. Highly commended posters, Sandra and Joanna for implementing a dysphagia therapy outcome measure within a paediatric speech pathology service. Congratulations to you and $100 in prize there. And another high commendation to Pamela Jinsey and David for the relationship between body mass index and sleep in women with risk factors for gestational diabetes, and well-deserved prize of $100 for them too there. So thank you. Other prizes this afternoon, amazing results with which were really close. So our oral presentations, best oral presentation was for Dr. Elise Hickey, $750 for the prevalence of anxiety, depression and chronic stress in adults with class 3 obesity and impact on weight loss over 12 months in a multidisciplinary weight management program. So a huge congratulations to you, Dr. Elise. High commendation to Dr. Mega Badhaid, $250. Congratulations. A retrospective analysis of trends in hospital admissions in patients with cirrhosis in the Macarthur region. The rapid fire oral presentations. The best rapid fire presentation was to Juniper Cheng, $400. Congratulations. Real world survival outcomes for patients with high PD-L1, advanced non-small cell lung cancer who receive chemoimmunotherapy versus immunotherapy. High commendation to Dr. Andrew Clarkson, $200, real world characteristics and outcomes of potentially resectable oligometastatic colorectal cancer. So thank you to each and every one of you and a sincere congratulations. Moving on, I guess, to the closing address. Just waiting on Professor Bouquet to join us.
I am here.
Excellent. Welcome to you.
Thank you very much indeed. I hope you can see me there because I can't see myself. But well, first of all, can I say what a very enjoyable afternoon this has been, and I'm so very proud and humbled to be part of Southwestern Sydney LHD, but in particular part of the Campbelltown Research Showcase. I really think this has been an inspirational afternoon. Congratulations to you all. In particular, congratulations to the speaker who've highlighted their research, outstanding research, and in many instances, the sort of research that I would expect to see at an international meeting. So congratulations to you all. I'd like to thank the organisers, Elise Baker and Annette Toniello. You've done such a wonderful job. Congratulations to you. And you were very ably supported by Judy Redding and Leila Muhammad. And thank you both as well for making this afternoon so very special for us. I'd like to thank the Research Directorate, Ellie Pavlov and her team at the Ingham Institute. I was very excited to see the Macarthur Medical Research Centre. This is truly an outstanding announcement, and the photographs that Anne-Marie showed us. You know, who would have expected this 5 years ago? And thank you, Anne-Marie, for pushing this so hard, and for everyone who's worked hard to make the Research Centre not just a possibility, it's going to happen by 2023. And it will reflect the research aspirations of clinicians, researchers at Western Sydney University, University of New South Wales, Southwest Sydney LHD and the Ingham Institute. I'd like to also thank, on your behalf, Western Sydney University for its sponsorship of our prize winners, but everyone who presented today is a prize winner. And I congratulate you all for a most enjoyable afternoon. Thank you again.